Should I start?
Yes, Dr. Ved Prakash Mishra ji is the first speaker and Dr. Rajendra Iran is the chairperson. You can hold on.
Right. So, Rajendra,
Sir,
just get
yes.
ready and chair your session. And we are all waiting so eagerly to hear both from you and Ved Prakash ji. Please start.
Thank you very much.
Thank you.
Thank you very much, sir. Good morning to all and to our National President, Dr. Sharad Kumar Agrawal, our Honorary Secretary General, Dr. Anil Kumar Nayak, our Honorary Finance Secretary, Dr. Kshitij Bali, our President-elect, Dr. Ashokan, our immediate past President, Dr. Sahajanand Singh, and our Chairman, sir, Dr. DJ Bora sir. It is my privilege, and I feel very much excited to introduce to someone who doesn't require any introduction. He is encyclopedia. He is very well known, not only in this India, but all over the world. And just few words for him. And I am sure that these words will be less for him, but I have to give some brief introduction. Dr. Ved Prakash Mishra, a Saraswati Putra, and he is having the command not only on medical subject, but each and every subject which is related to humanity and the language. Dr. Ved Prakash Mishra is Professor of Excellence, Professor of Eminence, and Professor Emeritus, and he is also known as Distinguished Professor. Dr. Ved Prakash Mishra sir was awarded B.C. Rai National Award for Eminent Medical Teacher for the year 2016. He was awarded in 2017 by the hands of our Honorary President of India. He was conferred with DSc by 7 Health University of India and 1 DMSc by 1 Health University of India. He is having 96 registered copyrights to the credit in the domain of medical education. Presently, he is Principal Advisor of Honorable Chancellor of Krishna Vishwa Vidyapeeth, deemed to be University Karad. He is Pro-Chancellor Datta Mega Institute of Higher Education and Research, deemed to be University Nagpur. He is Head of the Medical and Health Professional School of the Indian Program of the ISB UNESCO Chair. He is member of the International Committee for Bioethics for Asia Pacific region. He is advisor, Human Ethics Committee Association, Bangalore. He is chairman, Academic and Accreditation Board, National Indian Medical Association, New Delhi. He is special advisor to Indian Medical Association headquarters, New Delhi. He is director, professor in advanced physiology, professor of eminence, excellence, emeritus with 5 health sciences university in the country. He is honorary IMA professor, Indian Medical Association headquarters, New Delhi. He is honorary director, Center for Health Policy Planning and Education Research, Datta Mega Institute of Medical Sciences, deemed University Nagpur. He is chairman, National Medical Education Board, IMA headquarters. He is member, National Advisory Council, Indian Medical Association, New Delhi. He is academic head and convener, Academic Council, SARC Medical Association. He is Vice President, Management Committee, Education Program Society of India, New Delhi. He is member, Advisory Board, Manipal Academy of Higher Education. He is member, Advisory Board, Adi Chungari, University, Karnataka. He is member, Board of Management, Shri Ramchandra Institute of Medical Sciences, Chennai. He is member, Board of Management, Shri Balaji Vidyapeeth, Puducherry. He is member, Board of Management, Yene Poya University, Bangalore. He is member, Board of Management, D.Y. Patil University, Kolhapur. He is member, Board of Management, Dr. D.Y. Patil University, Pune. He is member, Court of Sharda University, Noida, Uttar Pradesh. He is life member, B.C. Rai Memorial National Endowment Fund, New Delhi. He is member, Governing Council, Kasturba Health Society, Sevagram, Varda, that manage Mahatma Gandhi Institute of Medical Science, Sevagram. And he is convener, experts group of National Board of Examination of New Delhi. I think what he is not, these are only the few lines which I have read, but he is, what is from my experience, I can say, he is the encyclopedia of medical science in the world. Thank you very much, sir, and welcome, sir.
Thank you, esteemed Chairman, my learned brother, Dr. Rajendra Iron, Chairman of the IMA Ethics Committee, my esteemed brother and Honorable Vice Chancellor of Shankardev University of Health Sciences, Assam, Dr. Dhruvajyoti Bora, all the learned, esteemed colleagues who will be participating and delivering their dictions in this webinar, which has been scheduled by the Indian Medical Association through its Ethics Committee. Esteemed my learned brother, Dr. Dateshwar Hota, Honorable Vice Chancellor of Orissa University of Health Sciences, past National President, IMA, Dr. J.A. Jailal, esteemed Dr. Girish Tyagi, Dr. Menon, Dr. Parekh, all the leaders of the IMA who have joined this webinar, National Chief of IMA, respected National President IMA, Honorary Secretary General, immediate past President, ladies and gentlemen. At the outset, I would like to record my sense of thankfulness and gratitude to the IMA Ethics Committee to have ventured into taking this very notable initiative of organizing this webinar on very vital thematic depictions, which speak volumes about the constructivism that is there in the mind of IMA Ethics Committee for the propagation of a larger cause. And therefore, ladies and gentlemen, opening the entire discussion on a theme wherein professionalism and professional ethics turns out to be a must mandate for profession. To begin with, I'm just wanting to put across that we say that we are a civilized world. We are a cultured world. When we put these two adjectives before ourselves, ladies and gentlemen, what exactly is being civilized and what exactly is being cultured is something which is required to be taken note of. Man evolved over a period of time which took millions and billions of years from a caveman to a modern, civilized, cultured, educated, and a man of substance and eminence. What is this transition all about? It is not just a transition of the materialistic growth that has accrued over a period of time, but one cardinal principle which has really been the entire essence of the civilization of men and mankind, ladies and gentlemen, has been very beautifully marked by Alvin Toffler when he says that it is a shift from a principle operating in a barbaric caveman to the present civilized man, which has made the difference. And that cardinal principle is that a barbaric man was operating on the principle of, quote, might is right, unquote. And the shift to civility is that now it is right is might. This is the cardinal shift which goes to indicate that the entire civilization revolves around one simple fact, be it civilization, be it civility, be it culture, including what Socrates calls as egalitarianism. It invariably revolves around the paradigm shift from the cardinal societal principle of might is right to right is might. And therefore, there are two important words which now are govern the society in the form of what we call as four important things. A, norms. B, values. C, traditions. And D, conventions. What exactly are all these? I am not just talking of codified laws and I'm not talking of the enacted laws. They are a further step of development. What is right and what is wrong? And what is right and what is wrong, and a step above what is righteous. This is the trinity, ladies and gentlemen, which ultimately governs what we call as the conscience of the human society as a whole. It is in this dictum lies what we call as ethical principles which are required to be put across for the purposes of putting the entire gamut of human civilization, in which medical profession turns out to be one of the important entities. Having said so, I'm straightway wanting you to be coming down to, I'm not talking of the ethics in terms of its ancient principles, medieval principles. I'm straightway bringing you to the important landmarks of the 20th century. The horrors of the World War, especially World War II, which resulted in a loss of mankind which was absolutely open-endedly unending. And therefore, post-1945, three important paradigms have been worked out. One, International Charter of Justice, ladies and gentlemen, turns out to be a cardinal document. Arising out of the International Charter of Justice is generated International Code of Ethics. And out of that, the third important document which the whole world knows is the UNO Declaration. Important aspect of UNO Declaration getting translated into Geneva Convention in the aegis of World Medical Association in 1948 turns out to be an important landmark linked with three other important documents. A, Helsinki Declaration of 1964 pertaining to biomedical research, 1986 New Policy Education Document, 1993 review document pertaining to medical education of A.K. Mukherjee Commission, 2000 Medical Council of India coming out with Code of Medical Ethics in the form of a regulation notified under Section 33 of the then Act, repealing the governing cardinal guiding principles pertaining to the professional ethics, to 2005 UNESCO Declaration, and then finally 2021 repealing of the earlier Code of Medical Ethics Regulation, now notified by the National Medical Commission. I am taking this entire transition in regard to codification of what? Codification of norms, codification of values, codification of ethos, codification of ethicality, codification of morality, and codification of value basis. These are the five cardinal considerations which were put across by Socrates when he contemplated the entire concept of a state and an egalitarian society. These are the five dimensions which are absolutely encompassed. And the journey which we have taken over a period of time is now culminated into the 2021 regulation, which is finally repealing the 2000 regulation. What exactly is the constitutional mandate in this regard has to be taken note of. And the subtle difference between what I am trying to draw home should be in a position to make a clinching difference. 1947, we became independent. 26th of January, ladies and gentlemen, we adopted our constitution and India became a federal republic, federal democratic republic with sovereignty in terms of Constitution of India. In Constitution, we have got certain fundamental rights which are bestowed on all the citizens of this country, embodied from Article 12 to Article 32 in chapter called as Chapter 3, titled Fundamental Rights. I am specifically drawing your attention to Article 19 of the Constitution, subclause 1 thereto, and subclause G of clause 1, meaning thereby, Chairman Sir, I am referring to clause or Article 19(1)G of the Constitution of India. It gives every citizen, it guarantees every citizen of this country of yours and mine a fundamental right of earning our livelihood by certain ventures. And those ventures are called as trade, calling, order, vocation, occupation, and profession. Why I'm listing this? Because all of us are entitled to earn our livelihood in terms of a guarantee given by the state for decency and dignified life, guaranteed under Article 21, in terms of either a trade or a calling or an order or a vocation or a occupation or a profession. I am wanting the last two words which have been put across are occupation and profession. I would like to make a subtle difference which is incorporated therein. All occupations are not professions, but all professions primarily are occupations. What is that which converts an occupation into a profession? Medical practice being done by you and me is not an occupation, ladies and gentlemen. It's not a trade. It's not a calling. It's not an order. It's not a vocation, but it is a profession. Therefore, I'm wanting to put across what is that which makes the Constitution to put profession at the highest pedestal of earning of the livelihood. Point number one. And what is that which is so sacred, which is so different, and which is so distinct, attributable to an occupation being designated as profession? Ladies and gentlemen, I would like to recall three important parables which convert an occupation into a profession. An occupation getting converted into a profession requires the first requirement of a structured program for teaching, training, learning, and orientation, which is duly formulated and is approved by a designated authority, which goes to indicate that a person who is, when the occupation is born out of structured teaching, structured training, this predetermined learning, and a certification there too, in terms of it being duly endorsed, approved, permitted, and recognized by a competent designated authority. First requirement. Second requirement is there must be a registering authority for the purposes of formulation of the register of such people through a designated or a competent authority. And three, it is only upon registration with the designated authority that the person will be in a position to practice profession with certain riders being mandatory for him or her to follow. These are the three things which make an occupation get converted into a profession. Let us take the case of medical profession. I am again not taking you back to a detailed history commencing from the British time, but I am just putting across certain flags. 1904, the British Parliament constituted the first Indian Commission, including the Commission for Medical Governance of Education and Conferment of Degree. Chairman, sir, in 1916, Indian Medical Degrees Act came to be adopted by the British Parliament for India, wherein for the first time, Indian universities became entitled to confer modern medicine qualifications post 1916. But even then, in spite of the qualification being conferred, the registration was not with any Indian authority. It was with the General Medical Council of Great Britain. And therefore, in continuation with 1916 Act of Indian Medical Degrees Act, it was in the year 1934 when the British Parliament adopted Indian Medical Council Act 1934, upon which an Indian Medical Council came to be created, which became the registering authority for the medical practitioners in regard to the qualifications which were covered and conferred by the Indian universities under the rubric of Indian Medical Degrees Act 1916. Post-freedom, we all know it for certain. Upon the recommendations of the first Independent India Education Commission report headed by Sarvapalli Dr. Radhakrishnan, 1956, we repealed the 1934 law, resulting in creation of the Indian Medical Council Act of 1956, which resulted in creation of the Medical Council of India as a registering authority for maintenance of the National Medical Register of registered medical practitioners in India. And finally, which came to be repealed in the year 2019 by the National Medical Commission Act 2019, and now National Medical Commission is the authority maintaining the National Medical Register of registered medical practitioners. Yet another important dimension which has to be borne in mind. Upon freedom, Constitution having accepted the federalism as a structure and the definition of India itself being incorporated in Article 1 as India / Bharat is a union of states. Therefore, the unitary composition of the country turning out to be in the form of states and union territories. Therefore, in terms of the federalism, subject list being created and health being incorporated as a subject included in the state list appended to the Constitution of India, state medical councils in each state for maintaining of the state medical register for the registered medical practitioners in the respective states came to be an operational entity in free India. Therefore, what I'm trying to put across, ladies and gentlemen, is very clear, and that is A, there is a restriction or embargo which is being put across. And what is that? All of us, upon procuring the registering medical qualification, Chairman, sir, MBBS qualification by the said nomenclature conferred by an Indian examining university, which is covered and defined under Section 2F of the University Grants Commission Act 1956, is entitled to confer a medical degree upon fulfillment and eligibility of the candidate turning out to be a part of the structured teaching, training, learning program and end certification thereto with completion of the rotating internship with provisional registration with the state medical council concerned is eligible for being registered with the concerned state medical council where he or she wants to enroll. Let me put it across very clearly. I may be an MBBS degree holder, but if I'm not registered with a state medical council or my name is not included in the state medical register or the national medical register, I am not entitled to practice medicine, which goes to indicate that registering medical qualification only upon solicitation gets converted into a registered medical practitioner. What are the rights and privileges which are conferred by the registering medical council on the registered medical practitioner? There are 4 rights which are conferred: right to practice medicine, right to profess medicine, right to prescribe medicine. But the 4th right is important. Dispense all these within the tenets of 3 important things: ethicality, morality, and value ethos, which in the year 2000, Dr. Aaron and Dr. Dhrubajyoti will recall with me, the architect for the first proposition of codified medical ethics, and that is a law of the Medical Council of India, which is prevailing and which is guiding the entire country in regard to conferment of the medical privileges to practice within the tenets of ethicality, morality, and value ethos, which is called as Code of Medical Ethics, Etiquette, and Behavior, ladies and gentlemen, which goes to indicate that right to practice is not an absolute right. Right to practice is with certain reasonable embargoes, which are moralistic in nature, ethical in character, and value-based in ethos and operation. This is exactly the point which I'm wanting to draw home. The real mandate for medical profession is not right to practice. It is right to practice with certain reasonable restrictions of morality, ethicality, and value ethos. It is this trinity which has to be borne in mind. And it is this trinity which is not accidentally born, ladies and gentlemen. It is a trinity which, in terms of the modern parlance, is generated out of the UNO Charter, is generated out of the International Code of Justice, International Code of Justice, International Code of Ethics, Helsinki Declaration, UNESCO Declaration, and it is including Geneva Declaration. All this has culminated in incorporation of an operational professional ethics, which is mandated for the purposes of practicing modern medicine by every registered medical practitioner. The 3 important aspects of that have to be taken note of. Any ethical wrong, that is breach of code of medical ethics, it is the registering medical council which has got the disciplinary jurisdiction. Any civil wrong incorporated therein, along with the ethical wrong, it is the civil court, including the Consumer Protection Act, which is there, which is endowed with the authority to be dealing with the matter. And any criminal wrong is expected to be taken by criminal procedure court with a sessions or a criminal court, as the case may be. The 3 arms are very loud and clear. They can operate isolatedly and they can operate concurrently as well. That is not the aspect which I'm wanting to deal today. What I am wanting to deal today is absolutely 2 important aspects. Why professional ethics? It is not just an incorporation of nobility, Chairman, sir. There are 2 important aspects which are uniquely attributable to medical profession. And they are: medical profession has to be humanized and medical profession has to be socialized. These are the 2 important arms which can be said to be the soul of medical profession. How do you ensure humanization of medical profession? And how do you ensure socialization of medical profession? Ladies and gentlemen, it is the ethical principles which are responsible for incorporation of these 2 important special features of medical profession to be practiced by medical practitioner as a part of it being a sacrosanct duty cast on him or her. This is the mandate which I was wanting to be incorporating by the word professional ethics as a must mandate for medical profession. How exactly this has been worked out? A bit of historicity, ladies and gentlemen. If you look at the entire chronology of the documents, 4 important principles have been generated for the purposes of evolution of professional ethics, including ethical conduct in the society. And what are they? The professional ethics revolves around 4 cardinal principles. A, the principle of beneficence. B, the principle of non-maleficence. C, the principle of autonomy. And D, the principle of justice. This is basically, these are the 4 arms which ultimately to go to govern what exactly is the ethicality, morality, and value ethos incorporated therein. When I'm wanting to put this across, ladies and gentlemen, one of the important, I have tried to bring that out into operational bits. There can be a large thing which can be taught about all these 4 principles, but I am talking to a very elite and select gathering. Therefore, I am wanting to put across, when we talk of these 4 principles, when we say beneficence, what exactly is the ethical conduct, moral conduct, and value-based conduct which is expected? Chairman, sir, the 3 important dimensions which can be included is A, it is the altruistic skills which turn out to be the core part of beneficence. It is the commitment to the benefit of the patient which turns out to be an important part of the entire dimension of beneficence. And it is an open, unended quest on part of the registered medical practitioner to excellence for the dispensation of beneficence. The 3 arms which are mandated for the purposes of governance of the professional ethics in the principle of beneficence, they are A, altruism, B, commitment, and C, unending quest to excel for extension of beneficence. When we talk of non-maleficence, again, Chairman, sir, the 3 arms which can be which have been attributed to the non-maleficence are A, it is not just cure, it is care and cure. One part. It's not just responsibility, it is responsiveness. When responsibility gets converted into responsiveness, when cure is blended with care, and when sensitivity is the icing on the cake, take it for granted, the principle of non-maleficence stands catered to. When we are talking of empathy, ladies and gentlemen, again the 3 arms, which are the operational arms of empathy, the autonomy, and that is empathy, blended not sympathy, compassion, blended with concern, respect, blended with dignity for the patient. This is the autonomy. The autonomy dimension of the principle is extended by these 3 arms. And when we talk of justice, believe me, the 3 arms which govern the justice are honesty, integrity, and accountability. Ladies and gentlemen, these are the dozen, or which is called as the virtuous dozen. Each principle governed by 3 outcome-based attributes makes the 4 principles which are the cardinal principles of professional ethics in terms of their actualization and operationalization turn out to be an entire paradigm of 12 beautiful arms, 3 each attributed to each in its most generic sense, which makes, or what is classically called, Chairman sir, is a virtuous dozen governing professional ethics. Ladies and gentlemen, important aspect now linking it with, because one of the common features that we were always there, plagued by over a period of time, is professionalism and ethical conduct there too is quote unquote caught through our emulative role models and is not taught quote unquote. This is the dictum which has been breached and broken deliberately for the first time. And Dr. Aaron and Dr. Dhrubajyoti Bora, including Dr. Dateshwar Hota, will bear a testimony that the Medical Council of India undertook the onus and responsibility of creating competency-based medical education under the aegis of the Academic Council of Medical Council of India, which I had the fortune of heading, wherein we readied the entire course material for undergraduate medical education, incorporating therein an important creation in the affective domain of the curriculum, which was ATCOM module, attitude, ethics, and communication module, spreading it over the entire curriculum, working it out as incorporation in an ongoing manner, creating it into competencies, breaking it into assessment, and also working out the teaching modalities, including allocation of hours there too, which goes to indicate that we have come on to a situation that in order to tide over this gap between the doctor, patient, and the relationship which is getting put to traumatic trot, it is imperative that the structured part of the curriculum and teaching and training should be revolving around the affective domain of the curriculum, which should be taking into consideration the domain of attitude building, the domain of incorporation and inculcation of ethical principles, including the effective communication blended with professional skills and the other associated altruistic skills altogether. 2001, I take an important landmark which I would like to narrate, ladies and gentlemen. 2001, when the Charter for Higher Education for 21st Century, which also included medical education, was declared, global objectives for medical education were crystallized by 142 countries to which India is a signatory. And again, I had the fortune of leading that delegation, and therefore I'm a signatory to that. The four important objectives that have been now set out for international medical education for generation of international medical graduate, inter alia, the international registered medical practitioner. There are four important objectives, and they are: every registered medical practitioner in the domain of modern medicine, arising out of the structured certification of the MBBS qualification, should be four important C's: A, competent; B, confident; C, concerned; and D, compassionate. This is the entire beauty. It is not just in isolation, the competence and confidence. There are four important C's. The final character and characteristic of the registered medical practitioner in the form of operational medical practice ought to be an intermingling of A, his or her competence; B, his or her confidence; C, his or her concern; and D, his or her compassion. And therefore, arising out of these four objectives, the five attributes which have been worked out are equally emphatically speaking. And they are: he or she, as a registered medical practitioner, should turn out to be a good clinician. Not only a good clinician, a good professional. Not only a good professional, a good communicator. Not only a good communicator, a good leader of the health team. And not only a good leader of the health team, but absolutely a lifelong learner as a whole. These are the gambits, ladies and gentlemen, which I'm wanting to put across in its entire context for a simple reason. Profession, medical profession without ethics, in my opinion, would be yet another occupation. The real beauty of the medical profession is its humanization, its humanization as an outcome, and its socialization as a charter. It's a commitment in terms of not only that it is put across as a part of ethical code, but believe me, it is an ethical code which is required to be put into operation on an oath. There cannot be anything more sacrosanct than oath. And that oath that you and me subscribe to is now born out of the Geneva Declaration. And if you read all 17 incorporations included in the Geneva Declaration, it is nothing but it is a treatise of absolutely four cardinal principles put into operation. One, beneficence; non-maleficence; justice; and autonomy. Therefore, ladies and gentlemen, it is not a fear of penalty or penalization that a registered medical practitioner ought to be intermoving his entire profession, plagued, dominated, and operated on the concept and ethos of professionalism. It's not a favor that you and me are required to be doing for ourselves, but basically speaking, it is an endeavor which has been the hallmark of medical profession, not today, since antiquity. And it is therefore, if I'm permitted to say, Chairman, sir, I say, what is the use of a body that does not have a soul? A body can have a soul anatomically, SOLE, but a body is expected to have a SOUL as the real guiding force. Professional ethics is the conscience of a conscious registered medical practitioner. A medical practice which is devoid of professional ethics is as barren, as hollow, and as mundane as any other occupation, vocation, trade, calling, or an order. Therefore, the main dictum that has to be kept and held uppermost in the minds of all concerned is that medical profession is a distinct entity, not for an earning of livelihood like any other profession, but it is a life which is plagued for the purposes of humanization and socialization through an instrumentality called as medical profession, which is plagued by professionalism, which is therefore dominated by professional ethics, both in letter and spirit. Thank you very much for patient listening, Chairman, sir, and all concerned. Thank you very much for this opportunity of sharing my views.
Thank you very much, sir. Ved, sir. Definitely, you have nicely differentiated profession from occupation. And that is the beauty of our medical profession. And these are the aspects what we are hearing nowadays, that medical profession is not honored as 20 or 30 or 40 years before as it was used to be. And this is the basic reason. Nowadays, the medical science is growing at a very fast speed, but it is in the technical aspect. We are producing more and more super specialists, but we are somewhere losing in our this medical ethics. And you have correctly said that, sir, you, Ved, sir, our DJ Bora Saab, our Dr. Nilesh Parikh, they are all, and I myself are witness that we have introduced the ATCOM module, and that ATCOM module will definitely make a big difference in our newer generation of medical practitioner. And Dr. Bora sir and Dr. Nilesh Parikh, I think they will remember it, that we were in planning to introduce that in each and every conference there should be some lecture on ethics, because what we are doing before this ATCOM module was introduced, we were only concentrating on our subject and subject to practice, but the practice was just an occupation, not in the professional manner as you have described. So this during our oath taking ceremony, if there is a lecture of half an hour to 1 hour of like this, I think our doctors, and if this sort of lectures are conducted during our conferences, they will better understand what is the role of ethics, what is the way to practice, and definitely it will make more respectable our fraternity, and definitely society and our country and world as a whole will gain much more from the medical knowledge we are having. And as we are having the unique aspect that we are knowing about the subject, and our customers, what they have labeled by our government, they are not aware of this, because we were not seeing them as a customer, but the government has labeled them as a customer, and that's why they have introduced the Consumer Protection Act, and this makes the big difference. And if we are becoming more and more ethical, definitely this doctor-patient relationship will be maintained in a better way. Thank you very much, sir. Thank you once again. Thank you, sir. Again to Dr. Bora Saab and Dr. Menon.
Culminating an excellent talk. One need not say that when that Ved Prakashji speaks, it is always excellent and illuminating. And Iran has done such a superb job in introducing and also summing up the whole first talk of today's. And I am grateful to both the chairman and also as well the resource person, Ved Prakashji, for this so excellent beginning with which we have started the day. Thank you.
Thank you.
Menanji, we can then go for the next one.
Yes, sir. We will take questions at the end of the session. Now we'll go for Jailal, sir. Dr. Jailal will be talking on ethical dilemmas, the way forward, and will be chaired by Dr. Girish Tyagi. Girish Tyagi, sir.
Yeah, thank you, Dr. Menon. First of all, sorry if I am traveling. There might be some issue with the videos and with the audio. As Dr. Jailal, the past national president, will be talking on the ethical dilemmas, the way forward. As we know that Dr. Jailal is a efficient and prolific speaker, and he has done the MS general surgery, DLS, that means the diploma in laparoscopic surgery. He has done the FRCS from Glasgow, UK. He is a fellow of International College of Surgeons, fellow of American College of Surgeons, fellow of Minimal Access of Surgeons of India, and fellow of laparoscopic surgery also. He has got various responsibilities. He has served as the various responsibilities to the various organizations. He was the Secretary General to the Commonwealth Medical Association in 2022 to 2024. He was National President of at 2020 to 2021. He has also been the national head of the IMA UNESCO Bioethics at Haifa. He has also served as the governing council member of the National Board of Examination. He was the member center of Board of Studies of Dr. MGR Medical University. He is the national faculty of Indian Association on Gastrointestinal and Respiratory Surgeries. He has a lot of awards in his name. He has got the best doctor award from the government of Tamil Nadu. He has also received the National Sardar Vallabhbhai Patel Award for Medical Education in 2021. He has got the Best Teacher Award from Dr. MGR Medical University, Tamil Nadu. He has got the Best Teacher Award from the IMA. And apart from these, he has published, he has got various publications under his name. He has got 30 research articles in the Index Journal. So Jailal will be talking on that ethical dilemmas, the way and forward. We all are very eager to listen to Dr. Jailal. Dr. Jailal, please, sir.
Thank you very much, sir. Indeed, it's a great privilege for me to talk with you, and I will start my presentation. Also, I will be talking with using my slides also. So it is a great.
Yes,
sorry.
sir.
1 minute. Okay. Yeah. So I bring greetings from our Indian Medical Association, National Headquarters, Commonwealth Medical Association, which I am serving as the Secretary General, and the UNESCO Bioethics, Dr. Russell, and the team of the people. The topic today I'm going to discuss to you is on the ethical dilemma. It is very difficult to talk after Professor Ved Prakash Mishra ji. What he has done a very, very excellent speech, and I'm little okay. The topic today I'm going to talk to you is on some problems are here. Ethics, we all know it is a group of moral principles or the set of values that define or direct us to do the right choice. This we all know. The importance of ethics, which when we are talking about, in a law, a man is guilty when he violates the rights of others. But in ethics, it is said by Dr. Immanuel Kant, even if he is guilty, if he only thinks of doing so, it's not even need not be do the things. And when we are have a thought of doing something, that also covered under the ethics. So this is a very important topic which we need to talk. And we are talking about bioethics, which is a bridge between the facts and the values. In terms of our own medical health, we say in between the facts between the clinical-based medicine and evidence-based medicine, that we are going to have an ethical values. Ethical dilemma is a feature that every professional man will feel in his time, whether it can be a professional, social, and there are different encounters we face in the ethical dilemma. It is an ethical paradox or a moral dilemma to which to do and which we should not do. And when we have a choice of doing something, and it is a very difficult thing to choose, And what we are going to choose is going to decide on an ethical dilemma. It is a situation involving the conflicting moral claims, conflicting the ethical values, conflicting the legal values, all are putting the difficult job of we may have doing what is morally right, it can result in a bad outcome or a bad effect. Or we can do what is morally wrong, but sometimes it may do the good. And this is a dilemma or the conundrum or a paradox. And how we are going to deal is the topic which I am going to discuss with you, the learned colleagues of this medical committee. I must thank the entire medical ethics committee for doing this excellent job. We have in the society, when we are doing the profession, we have different things. Certain things can be ethically right, but it is illegal. And I still remember one of the very famous poets, Thiruvalluvar, he says that even you are allowed to tell a lie if that lie is going to bring unreachable a good thing. It may be ethically wrong, but it can be a legally right. There are incidents a patient can come to you with a 28 weeks of pregnancy, but your moral values, or sometimes you say, I'm not ethically competent or ethically not to do the abortion, but legally it is right to do an abortion. So there are issues which has something which is ethically right, legally not right, legally right, ethically not right. So how we are going to decide on this is a big question. The ethics, the values, the law, the moral, all four plays a major role in any professional decision making. Something which we need to go through that and take a decision. I just show you a picture. It is written in Tamil, but I just want to tell that there is a two man, mine and husband and wife. They are traveling in a donkey. There are people who is seeing that. They say, oh, what a poor man. This is that. They have no heart on this. This donkey is a very small, poor donkey. How can such a big two people can sit on the donkey? This is a statement made by the people who saw that. Immediately that man thought maybe it is right. Then both of us should not travel. So he thought that he will get down. And he allowed his wife to get down and he was just walking. There was some people with the female saw that. They said, hey, what man, he is a male chauvinist. He's not allowing, he's making his wife to walk and he is enjoying on the donkey. Hearing that, he thought maybe I am right. So he got down and allowed his wife to sit on the donkey. Again, people said, and he is a poor fellow. He is just listening. He is making his wife to travel and he is walking behind. Then he thought it is not poor. So both of us got down and they started walking near the donkey. Why I brought this? This was the situation that we are going to face. And whatever you do, there will be some people commenting on that. It will appear to be right. When the woman chauvinist is saying that husband is sitting, is making the wife to walk. Yes, it looks, it's okay. When somebody says that the man is sitting and he is not allowing his wife to sit, again it is right. And that is a good decision. But this kind of dilemma we will be always facing in our medical profession, and what we are going to do is a big issue which we are going to talk about then. The incident which court capture, when you are putting a light, yes, the patient will suffer. But for a purpose of teaching, are you not necessary to put the light to explain to the people? So this is a professional, when you are in the teaching profession, you get a dilemma. And when we see a picture like this, and it depends upon our mind and it depends upon the penetrating power with which we are looking on that, and we will be able to see. Somebody can see only an old man, somebody can see a beautiful lady here, somebody can see an animal sitting there. So all these are all are right, but all these are various issues which we are going to face in that. There is a different color, different shade, different paradigm for each thing, and with which that how we are going to face these ethical challenges and how we are going to take a decision is going to be the big challenge. And when you are trying for that, whether it is right or wrong, that when you are doing for that, the Newton's third law will say that if every action has its own reaction, so every decision which we are going to take is also going to make a big difference in that. And this is she was an old typist. when she is working on a computer, she is still the old habits are coming. So there will be a mixing of our what we thought originally 10 years back, what the evidence is coming and giving in a different way, but still we will be in a different situation. So how we are going to face it? I just want to put in front of you a situation. A patient had a retroperitoneal mass impinging on the ureter and progressed into renal failure. It's a huge retroperitoneal mass, nearly 15 centimeter mass is there. That is impinging on the ureter, by which of the ureter she is not able to pass urine and she is getting into a situation of the renal failure. The surgeon comes, he examines and he says, it is better you go for surgery. We need to remove these mass and that will be good for them. But the patient says, I am frightened. I am frightened about anesthesia. I am frightened about surgery. I do not want any injections also. She refuses to do surgery. So she is in a renal failure. The surgeon has to put it on a dialysis. So there is a question comes whether the patient, what to do for the patient. She is not obeying. The surgeon feels surgery is the best and she is afraid of surgery. And this is a dilemma which we will be getting. And when we are there and we have a guidance as already well explained by the Professor Ved Prakash Mishra, we have certain principles or the pillars on which that we are going to take a decision. And the the foremost pillar is the beneficent. And whatever you do, it shall be only in the interest of the patient and for the betterment of the patient. And non-maleficence, then do no harm. And whatever you want to think that maybe you are thinking it's a good, but our ultimate principle that we are going to decide, am I doing any harm to the individual? And the most significant is autonomy, the right of an individual, the right of the patient, the wish of the patient. The what is the patient is thinking as a right is also equally important. We cannot neglect that. Autonomy is a important thing. Justice, we have a limited resource and we need to give it in a ration or the proper way. And how we are going to do dignity, truthfulness, honesty. These are the principles or the pillar in which we will be taking a decision when we are facing with the ethical dilemma. And if you see this patient, the doctor must work with the patient to respect that she refuses for surgery. It's an autonomy of the patient. She has the right to refuse the surgery, which a surgeon has to respect. So autonomy is the principle we are here. And the doctor has the responsibility that he needs to do whatever it is good for the patient. He needs to find a solution and what best. The patient says no. So he must always find a solution for that. And against the wish of the patient, against the wish of fear of surgery, maleficence, do no harm. You should not have that feeling. So we cannot do that. But what is the problem I have? I have only 2 dialysis machines. And if I am putting this dialysis machine for this patient, another 2 acute renal failure patient may not get the dialysis machine. Because this patient, if you do surgery, it will be better for her. No need of a dialysis machine. Now, with a limited resource, I have to sacrifice 1 dialysis machine to another person who is a good person. He may not be able to get the right thing. So we in a dilemma. The autonomy has to be respected. The beneficence has to be done. We should do the justice also. So these are the incidents. And if you see one of the study which is done by the Rushworth Kidder in the US, and some physicians were asked, what are the challenges, the dilemmas, or the great dilemmas you face? It is a short term versus long term. You are giving a drug, and we know, for example, you prescribe the alprazolam or the diazepam. We know for the short term, it is continuously taking, it is going to be produce addiction behavior. How is the dilemma you have to decide? When we are taking individual versus community, when there is a COVID, we advise that everyone has to wear the mask. It is not only for individual, for the sake of community. And even somebody has to be not able to follow the rules and regulations. For the sake of community, we need to impose that against the autonomy of an individual. Truth versus loyalty, justice versus mercy. So these are the few issues which we face in the ethical dilemma. We conducted a survey, we conducted a study also on the people, and few questions were asked to the doctor. I just want to bring to you a kind notice and the few challenging areas where we had the problem. And the question was asked to the few doctors, will you recommend and administer life-sustaining therapy when you know for sure it is futile? There may be some demand is coming to you. Are you going to adapt to that? And you have a choice either to withdraw the life-sustaining therapy or knowing very well that it is not going to be a beneficial, you need to continue for that. A patient admitted in a terminal care, he says, still my daughter is coming and this person should be kept alive. So the doctor is putting on IV fluid, putting on the ventilator, connecting onto that. And this is a dilemma. There are so many people said, yes, I will do. And few people, the number of 37% of the people said, no, I will not do. I will stick on to the medical professional. And it all, somebody said, it all depends on the people. This is one dilemma we had. Similarly, the opposite of that, when you are taking that the family is demanding, let this poor man die, please don't put the life-sustaining therapy. But you are not able to take a decision that you know for putting a life-sustaining therapy, 10 to 20%, 30%, there is a possibility this man can come out of that situation. And how you are going to take a decision, again, there is 16% of the people said, I will discontinue, and 54% of people said, I will not do. This is another dilemma which the question was put. And when a patient is coming, how many of us write a placebo? We know for sure there is no role of that vitamin C, no role of that FSC, no role of that antacid, no role of that the therapy, the vitamin tonic which we are giving. But still, when the patient is asking, we are prescribing not a placebo medicine. And the patient is also believing that this doctor will not do any harm to me. So he goes and buys the placebo drug and taking, which we know for sure that it is not going to be of any help. And how many times we have written the placebo? It is an ethical question. Are you going to write the placebo, or we are not saying that, no, I will go by the medical evidence, medical evidence that I will not prescribe the medicine. Again, the 23% and 58% of the people who responded to in a different way. And when you are doing a terminal ill patient and you are making a diagnosis, pre-terminal diagnosis, and what information you are going to give to the patient? Are you going to say you are going to die within a short time? Or you are going to say that we are going to try our best, don't worry, you will come back? And how many, as a dilemma in front of us, to tell the truth or bolster the emotion of the patient? And again, and we will have the difficulty. Some people said, yes, I will give a soft answer. I will talk with the patient comfortably to get into that issue. And when we are doing a theater, when we are doing a mistake or something is happening in the mishap is happening when you are doing a harm, when you are knowing that iatrogenic infection has taken place, we know for sure it is not going to cause big harm. Are you going to say honestly that this is a mistake I have done, though I know for sure it is not going to make a harm to you? Or we saying that telling that my reputation may go, the hospital reputation may go, so I should not tell that. And when there is no harm is happening to the patient, and why should I come and tell to the patient that I have done this mistake? How many of us are truly able to say that with that? And whether when we are writing, when we are knowing that some mistake which has happened in the hospital, in the theater, and patient is going to have a potentially harmful effect, whether it can be a diathermy-induced burn, whether it could be a shock which is due to the mismatch of the drug, is a shock which is happening due to the blood transfusion effect. Are we going to tell that exact truth to the patient, or we are trying to cover up that many people said in a different way? And this is another major dilemma which comes to you when you are writing a insurance claim to the patient, and people come to you and ask you, hide that I am an alcoholic. If you are writing that he is a chronic alcoholic, the possibility of getting the insurance cover is low. Or when you know for sure the diabetes is there for 10 years and the patient will come and bother you, that don't write that. And then it will be my claim will go away. And how many of us listen to that? And it cannot be said right or wrong in an absolute term. And whether the patient is going to get benefit, or you are going to say that my reputation, my loyalty is going to be there, and it can be ethically right and legally wrong. So this dilemma, which we always use many times, it is happening in that. And this is another dilemma. And medical ethics says you should not discuss the identity of your patient and issues of the patient with another person. And I often remember Dr. Vinay Agarwal, our ethical committee chairman, used to say, not even discuss with your wife about the patient. And his details of the patient, you shall not discuss even with his own wife. And that kind of thing, is it possible when we are coming for a party, when we are meeting together, when we are presenting our case? Many times we are making the identification of the patient, and the identification of the individual is being taking place. Another dilemma we are going to get is agreeing for a gift or a compliment which you are going to get from the pharmaceuticals. And are we going to accept? And somebody, a representative, is coming and giving a pen or a pad, and are you going to accept that? And I still remember that K.P. Agarwal will always used to talk the ethical way of doing unethical things. And he says that up to 999, rupees worth gift you are purchasing, it do not come to the reprimanding or the stricture by the MCA. That time MCA ethical committee do not say. You can get up to 999 rupees worth. But when you are getting 1,000 rupees worth gift, it is punishable or it has been reprimanded. And how the principle of ethics, whether is it not the punishment it is going to be there, and I'm going to accept the gift coming to you in the whatever way. Are you going to have any relationship, sexual relationship with our patient? And whether it is morally or legally is it permissible? There is nothing, no legal, legally it is right. Nobody can question you. Even a patient who is coming to you, the patient is on your treatment, you can marry her as long as she is accepting. But is it ethically right? That ethical dilemma comes to that. Many doctors said up to 6 months I will not do, and people said no, absolutely. Everybody said I will not do that, and this kind of problems we are going to face. And organ transplantation, a huge waiting list is there. But when the rich man or a politician is coming to pushing you to bypass the queue and give that organ to somebody is not in the waiting list, but somebody is, because it's a politically rich man, when he is coming, and how you are going to respond to that is a big challenge which we are going to face on that. And referring a patient, again, many times we know for sure that it's only for protecting the doctors. We are referring the patient to some consultant, or we know for sure that this patient is not going to get the exact benefit by going to there, but still that sometimes the patients are referring. These are the dilemmas which you are going to do. And MTP, when it comes to you, whether the law says that you can do that MTP, but your religious belief or your religious values or your concern, you say that I will not do that in MTP. This is an issue you are going to do. Patient is another. These are a few examples of dilemmas which we will be always facing. The breaking the confidentiality with the patient. This all the few of the issues, and what kind of degree going to put. The ethics says very clearly that unless it is approved by the MCA, it cannot be put. That is legally all right. But many times we put the fellowship. Many times we put the which we always find explanation for the things which we are going to do. So this
क्या ये एक मिसमैनेजमेंट को दर्शाता नहीं है? सरकार अपनी मिसमैनेजमेंट को
The voice is not coming.
Jalal sir?
yeah.
There is some
Now it's
problem.
audible, sir. Hello.
Yeah, yes.
Okay.
Yes.
Okay. So approaching an ethical dilemma, recognition of the situation and raising the ethical dilemma, breaking the dilemma into component parts, seeking the additional information, including the patient's view, our professional view, the peer group view, then we will be able to take a decision. So that is why this ethical committee of Indian Medical Association come into that. Individually, we may not be able to take a decision. Challenges comes that ethical committee or the departmental ethical committee, or when it comes to the association of the peer group ethical committee, or our own the specialty organization that put their thoughts together, they will be able to break down that component. And again, on the basis of the principles of the areas not available, but one of the best is always referring to the ethical committee, and which will be able to help us to get into the solve out these ethical problems which we are facing. It doesn't matter that we are never caught. That is mean that whether I will be law, whether I will be punished, nobody will see that. If I do that, nobody is going to understand this. So that is not the way to come out, but putting it and identifying the issue. Like what the ETCA module, which was once set upon the ethical dialogue, can't say people, we need how much information to give to the patient. This is another big problem we will face. Now, many times, we get a consent without explaining the situation to the patient. Without many times.
Your voice is breaking, sir. I think connectivity problem with the Professor Jailal. Jailal, sir?
And how much portion of the body is getting exposed? I'm not going to the details, but I come into the close end and how we have to face. There is no wrong thing, but always to do that. And it is not that we are going to perceive, but what we have to discuss with our committees, discuss with our own people, and get into that thing. These things, everything is possible for a law, but that things from yourself, you will learn. Something to
Your audio and video is breaking, sir. Jailal, sir.
Is it our problem or is it his?
Probably Dr.
his-
Jailal sir's connectivity issue, I think, sir.
Sir, side.
Dr. Jailal sir has got a poor connectivity, it seems. Jailal sir?
Seems to be connection problem. Net problem.
Yeah,
Yes, sir,
the
yes.
network issues are there. This is always issue with the online meetings. No?
Yeah, it is always. And with Biparjoy,
No, he's trying to get in. He's trying to get in. We will wait for 2 minutes, sir. He's trying to get in back.
Because I'm in a so you can go ahead.
There is some break in your audio and video, sir.
and if you can get good audio, then
Yeah, without video you can talk.
yeah, without video you can continue.
That will be ideal. Jailal, sir. You can talk without your video, sir, please. Sir, you can talk without the video, sir. Gerald, sir,
Yeah.
without the
No, but
video.
something is happening.
Yeah, you please talk without the video.
So what I have brought into the view, we are going to face there's a lot of dilemmas in our side. So let us make use of these ethical committees in our respective institution, respective place, respective in IMA. So when these dilemmas are facing, we should realize that this is a dilemma. Let us not feel that whether I'm doing is right or wrong, it is not going to punish, but let us make it open, discuss with the people, get the opinion of the peer group, get the opinion of the people, and do things as far as possible in a right way, the right thing at all the time, so that with an objective, let us preserve autonomy, beneficent and maleficent, and the justice to the community and society. Thank you very much for this opportunity to be with you, sir.
Yeah, thank you, Professor Jalan, for enlightening us on the ethical dilemmas, the way forward. As you told about what is ethical right may not be legal right, and what is the legally right may not be that ethically right. But of course, we all doctors have to use the ethics, and we should also know the ethical. Every medical practice should go to the IMC regulation 2002, which are still in place, in spite of the National Medical Commission coming into the picture, and National Medical Commission is also coming out with that ethical issues, what all doctors do. So in the present era, when all the peoples are aware ones, the patients who are coming are also the aware ones, and they know that what the doctors should do and what the doctors shouldn't do. So we have to be very careful in dealing with it nowadays. The patient as the ethical part, the most important part is the consent and the confidentiality part, because the consent is very, very important from the point of view that to whom the patient we are treating, he should be communicated with what the procedure is going to do, what will be the cost, what will be the complications. If there are alternatives, they should be explained, and valid and informed consent. And if we are doing an invasive procedure, the consent has to be informed consent. The patient signature should be there. Patient should be told in his vernacular language. And because at Delhi Medical Council, we are receiving number of complaints because of the consent itself. And as previous chairman, Dr. Rajendran, told that we have to tell our IMA members about the ethical issues. At Delhi Medical Council, we are collaborating with the Delhi Medical Association, and through the Delhi Medical Association, we are going to the different branches and taking up the topic of these importance, which because of which we are receiving the complaints, maybe because of the consent, communication, documentation, etc. So, and we at Delhi Medical Council, we have the CME which we are accrediting. It is mandatory on the part of the organizer to have a half-an-hour lecture on ethical part, so that our members know that what is the ethics, because we are doing a good work, but we are not, sometimes we are not communicating, and sometimes we are not documenting. Because of that, we are landed up in trouble. So once again, Professor Gerald, thank you very much from our side. That it is always pleasure to hear from you. But because of these network issue, which of course is the network issues, some in between your voice and video interruption were there. But in spite of that, you spoke very well, and we learned a lot from you. Thank you, Professor Jalal, sir. Over to Dr. Menon and our chairman, sir.
No, it was really a illuminating talk, and I thank Professor Jailal and my friend Girish Tyagiji for being with us in this session. I want to share with you just one very small thing. See, we have to be always aware of the particular Indian situation where our Indian doctors practice. As per strict ethical guidelines, you cannot share the details of the diagnosis or the condition of the patient with the attendants unless the patient himself agrees first that yes, the doctor can share this. Now, here comes a different problem which I had an opportunity of studying, is that in our society, the friends attendants, and the relatives form a support system for the patient's treatment. In absence of a credible social welfare system, it is the patient's attendants, relatives, and friends who provide the social support system to a patient, which may not be that strong in the Western countries. And it must have been they who have brought the patient first to the doctor. And in a large number of cases, they will be sharing the cost of the treatment as well. Now, in such a situation, I think an Indian doctor should, wherever possible with the consent of the patient, share the details of the treatment plan, everything, with the attendance of the patient. That goes a long way in actually treating and helping the patient. I leave it to my friends, learned friends, to think about this. And this should be I feel, a practice which we should follow in our day-to-day practice. That will be helpful to us. So with these words, thank you, both the participant and the chairperson. I think we can go to the next agenda of today's talks.
The next topic is again by Professor Dr. Datteshwar Hota on the NMC guidelines on professional ethics. And I think you will be introducing him, sir. Chairman.
Yeah. So Professor Hota actually does not require any introduction. He is an excellent urologist, and he has been in practice and in the academic sphere for a long time in the state of Odisha. And there his contribution towards both academic and also towards development of this particular branch of science has been recognized. And I'm so very happy that Odisha Health University has come into being, and Professor Hota was instrumental in its birth, and the government has recognized his talents and have made him the first Vice Chancellor of this Odisha Health University. And I hope under his leadership, this university will grow. During our times when we worked together in the ethics committee and in our other committees of Medical Council of India for a long time, we had very close interaction and we worked together as a team. And Parekh and Iran was also together with us. And I cherish the memories of those days where we had to deal with various kinds of ethical problems. Now the things are changing. After MCI, it is now the NMC, which has taken up. And I would request Dr. Hota to talk about it. I will share my views only after when his talk is finished. So Dr. Hota should start now.
Good morning. Thank you, Professor Bora, for the nice words. Dr. Sarath Kumar Agrawal, President, IMA. Dr. R.V. Asakan, the immediate past President. Dr. Sahajananda Singh, the President-elect. Dr. Anil Naik, Secretary General, IMA. Dr. Kshitij Bali, Honorary Finance Secretary, my fellow speaker, Professor Dr. Ved Prakash Misra, Dr. Jailal, Dr. Nilesh Parikh, Dr. Shiv Kumar, and of course, Dr. Menon and Dr. DJ Bora, Professor DJ Bora. I'm thankful to all of you and particularly to Professor Bora for giving this opportunity to address on a very, very important topics related to ethics in our profession. I also welcome and thank all the chairpersons for these deliberations. At the outset, I would like to recollect the words of our esteemed Professor Ved Prakash Misra when he mentioned about two captions. And those are very, very important captions. Occupations and professions. Well, he so nicely, lucidly mentioned about how a occupation becomes a profession. So there is nothing to mention on that. I have one thing to add to it, if I may be permitted by Professor Misra, that when we talk about profession, we must also think about a passion into the profession. So all are professional, but very few are passionate about the profession. And once a person has a passion to the profession, then automatically things becomes more oriented towards ethicality. The second thing he mentioned was very, very interesting again, the example of body and soul. And I'm pretty sure all of us, my esteemed colleague also will agree. What counts is the soul. Body is only a manifestation of all the manifestations of the soul. So when soul is defective, the manifestation become errant. And from that point of view, soul is the ethics and a profession is the body manifestation. Now, there's a few two things I wanted to mention before I speak about the subject that I have been assigned. I was in NMC on 14th of this month, and I was trying to know about the newer guidelines, what has been prescribed by the NMC. To my utter dismay, I did not find one till that they have formulated. They are in the process for the profession. Then I realized that there is already in the public domain one aspect of the ethics that is for the medical college teachers. It would not be out of the place if I say that the ethics which is taught in their formative years of medical students, they carry it to the society. So we need to address this ethical issue right at the beginning of the career of a medical student. And that is how I thought, let me speak about guidelines on ethics for medical college teachers. Yes.
Screen.
Yeah. Perfect. Full screen. Well, all of you know, this is the temple of learning, where all the students have come in their very virgin, fertile mind. And if we can inculcate certain systems, which will be definitely deep-rooted when they go back and into the society for their professions. A teacher is a friend, philosopher, and guide, leads students from darkness of ignorance to the light of knowledge.
Sorry, your slides are not visible.
Is it?
Yeah.
Let me try again, sir.
Now it is visible.
Is visual now?
Yeah,
No,
now
visible,
they are.
sir.
Now they are.
Okay,
Can
sir.
make it a slideshow.
Yeah, I'm making a slideshow.
It's not very clear.
I'm not that technically savvy, sir. So let me try my best. Yeah, is it visible, sir, now?
You can make it full screen.
Yeah, I have full screen.
Yeah.
Is it okay?
It is gone.
It's okay now, sir?
No, sir, it is gone.
Gone again. There is some problem.
Just keep it as you, that's enough, sir. Fine, proceed.
Okay, this is okay. Now it must have gone.
It's there. It's there. You continue.
Okay. What should be a medical college teachers? And there are few things already mentioned by Professor Misra. He should be competent, caring and sympathetic, should be ethical in practice. He should have a role to develop competent, compassionate, ethical medical graduates. And all of you know, and particularly the COVID-19 has made us realize that the student population also contributed immensely as regard the care and treatment of the patients who are suffering from COVID-19. Most of the time in the medical college, they are the point of first contact. What should be the 7 qualities since ancient time as a guru? He should be scholarly. He should be having intellect. Should have a very good conduct. Should have acquired very great teaching skill. Repeated studying is a go of the time, and he should have the consciousness. And finally, these are the 7 qualities of a good teacher is kindness. Now, in the teaching learning process, we need to not only tell about the course curriculum, and in the process of their learning, they must learn ethics, medical ethics simultaneously on a day-to-day basis. They should be aware about the curriculum. The teacher should be very aware about the curriculum, what he is going to teach. He should have the competence to continued professional developments. Whenever he is teaching, it has to be very contextual and should be contemporary. Quite often, we have experienced since our student days that the topic has not been focused and it has not been contextual. And many a time, some of the teachers, what they have learned in their time, they have not updated their knowledge and they are not going to impart contemporary teaching methods. And most of the time, it should be patient-focused teaching rather than a didactic lecture. You know, the new methodology of teaching that has evolved over the years, that whatever we have in the curriculum should have a focus on the patient. And the newer classrooms like flipped classrooms and the patient-focused teaching has a multi-dimensions which has been added recently. Whenever a class is taken on a particular illness or a disease, in the OPD or in the indoor, there has to be a connectivity to demonstrate them through the classroom so that they have a real practical knowledge of the teaching that is being given. Now, this is again very important. All of us, in fact, I was fortunate to have worked with Professor Ved Prakash and Dr. Bora and many more who are available here. Who have worked in the Medical Council of India. I have learned a lot from all of them. And what we realize that the plagiarism or the plagiarism should never be there in the medical teaching. Many a time, the teachers teaches to the students and he says that it is his own contribution. So it is mandatory that the teacher should reveal the source of information while he is imparting the teaching. And in the teaching learning process, we have to identify the students requiring special learning needs. There are many students which may not be up to the mark. They were really brilliant students when they have entered into medical, but they have not been able to adapt to the newer teaching methodology, the newer speciality. The teachers has to identify the students requiring special learning need. And he should understand and be very careful about his own limitations. And if needed, should always consult expert opinion. He should take expert opinion or advice from people who are very skilled in that area. Each one, what I am going to say, has an ethical connotation to each aspect of it. Now, again, another important aspect, what the teacher should be very careful about, that looking at his limitation, he should try to have a wider education system, wider participation. He should involve different departments and should have the maximal integration. The example that I gave, that at the bedside, the patient and the teacher is there in the theory classroom. The teacher is imparting the teaching and training. So the teaching and training goes simultaneously, the theoretical didactic at the lecture, where the teaching from the bedside by the teacher who is available there, he can coordinate and give a holistic teaching of the subject. Teacher is a mentor. He should lead from the unknown, and he leads from the known to the unknown. Rather, what is known, he should try to bring topic discussion which are unknown, and this will inculcate inquisitiveness and a research instinctiveness among the students. Then this is what the basic part of the teaching, and each part a teacher has to be very, very careful when he is imparting teaching. Now, the next job that comes is the assessment and the examination process. The examination has to be competence-based and should be a continuous assessment, not a one-time affair. Now, all of us have spent time in MCI. We have developed, and particularly I am really thankful and MCI owes to Professor Ved Vikas Misra, competency-based medical education, CBME. This term was acquired during that time. So not only that the competency-based teaching and training, there should be a competency-based continuous assessment. And the teacher should play the role of a gatekeeper. And while evaluating, the teacher should look to the 360-degree evaluation, which mostly, a teacher when he is in the classroom, he observes all his people and he tries to know what are the response of the people, and from that he can make an initial assessment, and he should go for a formative and a summative assessment as per the schedule provided. There should be a holistic teaching. This teaching should not be exam-based. Now here I would like to also further add that many of us have spent being in the medical colleges. The student joining in the MBBS career, he goes into some online training and learning. There are many agencies who are imparting a course so that the moment they pass out, they are ready with all those knowledge to appear for the NEET examination for their post-graduation. When they are doing this, they have been neglecting, ignoring their teaching and training which they are supposed to take care. So nowadays things have moved, and here we have to give emphasis that the teaching should be holistic and not exam-based. And as regard the exam is concerned, they can have a preparation separately. Now the teacher should have maintained the confidentiality of question papers. These are all ethical issues that I have been deliberating for all the teachers. Many times we have come across the teachers, they canvas for themselves. No, this is a tremendously unethical practice. And they'll lure sometimes some students that if you follow my way of teaching and all those things, you will secure very good mark. This is a wrong canvassing which should be dissuaded. Now the next thing that comes is teacher-students interaction, which is the most important thing in the medical education. there should be endeavor for new methodologies. The student-teachers relationship and interactions should be real, professional relationship. We should not cross our respected boundaries. Now, this is of prime importance that a teacher should maintain with dignity and should remain within the limit of the boundaries prescribed. The teacher should be very unbiased, fair, and should not be discriminating. Whatever I have been telling, these are all we have experienced in your days in the medical college, and these have far-reaching bearings. There should be effective feedback, and the feedback should not be punitive. Many a time, the teacher thinks that if we punish, the student might come back to a better state. But to contrary, our approach and attitude should be reformative. And whenever it is required in very cases of exigencies, disciplinary actions, it should be decided on a one-to-one basis. We must also follow that there is no humiliations of the students before the peers or the public. In a classroom, the student should not be given such words, should not be told such words which will make him low moral and which will create problem for his further persuasions. And a teacher should be available for clearing academic doubts. Many a time, the student asks a question in the class and the teacher says, I'll let you know later on. It is always better that the doubt which has been arisen should be cleared the very moment. A teacher should be a mentor, so he should be participating in all the mentorship program which is assigned to them. Many a time, you might have heard that a lot of mental stress and psychological trauma are happening in medical college because of non-adaptations and big expectations of the teacher from the students. So that need to be addressed individually. There should be areas of interactions where the teachers should try to know about the psychological stress and strain the student is undergoing while he is in the program. He should also address the additional need of the students. There are people who are high performer who possibly need additional, backup, additional training system to make it enhance his knowledge further. At the contrary, there might be many who are low performers and they have difficulty with the course curriculum. These two vulnerable groups, one is a vulnerable, is a high performance. Many a time he feels that possibly my learning in this place is inadequate. So these both the things has to be addressed by the teacher. Teacher should be facilitator to student for a SDL or the self-directed learning. You should encourage the student, gives problem, gives examples, and the student is encouraged for a self-directed learning. And he should be following the conduct regulations vis-a-vis pharma industry. Lot have been discussed, deliberated on this issue. If I remember correctly, Professor Bora, he gave his committee report as regard the interactions of the medical professionals vis-a-vis the pharma industry and other allied industry. That report was given. Based on that, some regulations were brought out. Now also the things are moving, and on these issues, a lot of things are happening. I would not mind to say that the professional bodies all over the country, the different professional bodies, they have not been able to check the rampant misuse of these provisions. Now, not a single national, journal, or state, the so-called CPD, the continuous professional development, is without a bad tinge of, professionals' involvement and unnecessarily rearing a lot of unethical practice. This can be discussed during our discussion, and we can give our viewpoint during that time. He should expose the student to common situations in the committee. Most of the teachers should take extra attention to tell about the common situations in the community and not to tell those unusual rare cases and make them aware about the disease prevalence in the community, addressing those diseases, knowing about all the detail about the disease which are commonly prevalent in the community rather than the unusual ones. This is again a very prime and important thing. The students, like the ethics they learn right from their medical days one, they should also be simultaneously taught about the medical legal aspect of patient care. My previous speaker, he also mentioned about this, the dilemmas, and these dilemmas has always resulted in a lot of medical legal complications. These students at the beginning should be told what is ethical, what is legal, and how he should approach in decision making. I will add further one thing, what my previous speaker was also mentioning about, that the decision should be a participative and a shared decision with the patient. And we should not jump into a decision on our own unless we have made the patient fully aware about the thing that we are going to do, whether the medication or the surgical procedure, what are the pros and cons, what are the likely outcome. Everything should be detailedly told to the patient, and this should start right from the medical student days. So for that, we have to be extra careful. That is one aspect, so that we should not face, neither the student nor the doctor should face any medical legal implications or a problem while the patient is being treated. Impart soft skills and counseling skill for empathetic communication skills to manage sensitive situations. And when I say this, the students right from the beginning should be involved in all sensitive situations with a good mentor as a teacher. Now, I'll give an example. A person dies while being on the treatment, and how to handle such a death, and we prevent the complications afterwards. These need to be developed. The soft skills and counseling skills has to be developed in the student to have a good outcome in sensitive situation. Now, I'm pretty sure when I projected this slide, most of my teaching faculty colleagues will realize this is the one that was the prime learning process of our time. But over there, I do not know why. I'm speaking from the context of the Odisha. Why this teaching has been relegated to background and given not given its due importance, even though all textbook, all regulations, all guidelines emphasize on this. Central to the practical and skill teaching. Without bedside teaching, one cannot acquire the practical knowledge. Demonstrate correct elements, and we should be very careful here. I think again I'll give an example that patient-doctor relationship has a limitation and has a boundary, and with this we must act within the boundary, work within the boundary, taking all elements to our considerations while we are treating. We must respect as a teacher the dignity, what has been told about autonomy, consent taking, confidentiality, and the rights of patients. The example, the index example given by our previous speaker, that he has a huge retroperitoneal hematoma, and the surgeon advised for a surgery, but the patient declined. He didn't want to go for a surgery. Possibly there where I would like to mention, possibly we were inadequate in telling the patient about the outcome of such a large mass. Had we got involved and really passionate in telling about the outcome, the worst outcome of such a large tumor. A large tumor obstructing one of the ureter will only give us a one-sided hydronephrosis that may not lead to renal failure. But the fact is that such a large mass, its malignant potential should have been explained. And when you explain about the malignant potential, and when there is a threat to the life of this patient, possibly he will agree. Also, we would like to mention there that such a large tumor is occupying almost half of the abdomen. When we go for exploration, there are few aspects we need to tell the patient. It may not be a resectable tumor. The tumor might be a malignant one. And while doing resection, there will be good number of complications possibly. But if we don't do the surgery, then possibly we are harboring a malignancy, which will be have a definitely evil outcome. So unless we have explained things properly, if we are not able to convince, let a team also discuss about this case with the patient. But the patient's right is primary. We cannot ignore the patient's right to refuse. He should understand the sensitivity to the patient's suffering and should be gentle during physical examination. This type of teaching will bring an awareness among the student how to handle the patient sensitively. Teach correct procedures on eliciting history and examination, more careful in women, minors, elderly, and with others requiring special needs. Conduct bedside discussions in sensitive manner that respect the dignity and rights of the patients. Many a time we have faced problem because of inadequate documentation. So this should be from the beginning of the teaching of the students at the medical college. We should always give the importance of the correct and complete documentation. Now coming to the relationship with colleagues, there should be a collegial relations. Senior faculty should be taken as a mentor to the junior faculty. Key role in CPD in and outside the institution. Even if I am a teacher in a particular institution, I should not be hesitating when required that in other institutions, if they are asking me to participate and contribute in CPD. Now, I think I'll have to quickly finish up because I'm almost crossing my time. When the teachers observe unethical behavior among colleagues, it is our responsibility and our duty to report to the appropriate authorities. Responsibility to the community. Obviously, we are meant for the community. We have become doctor for the community and we owe to the community. We have to stand in the society and individually and collectively, which can be used for a common good. Inculcate students with a sense of responsibility towards the community. The present NMC has already introduced the family adoptions for students. The students will be adopting 10 families in nearby localities to give them the feeling of a family medicines, and they can be a link between the institution and the family. And they should respond to calls for help in the event of disaster, health emergencies. As you know, I need not elaborate on COVID-19, the way we have, and particularly I am really grateful to IMA, the way IMA has responded to this threat of COVID-19. Health awareness, health literacy for making people to make better health choices and access. And role in research, this cannot be undermined. Research, you should be a role model and inculcate a scientific and research temper in students. Conduct research in lateral spirit as part of commitment to contribute growth of knowledge. special attention rights of research patient. This is again another area where a lot of unethical practice is going on. Special attention, the right of research patient. You know, the research patient should be fully informed. He should understand it well, and we should get a written consent, and at any point of time, their right to withdraw. Here, a lot of time we have crossed the ethical limit. Student and research volunteers, when students are the research volunteers, there should be no coercive influence. Particularly aware should be plagiarism, authorship, guidelines, falsification and fabrication of data, duplication of papers. These are all serious breach in research ethics and public confidence in genuine research. Oversight of research conducted as principal investigation of students, encourage research incubation program among the students. Now I summarize ethics of medical teachers. What are the issues? Each point that I have narrated has an implication on ethics. Ethics pertaining to the students, teacher-student relationship, imparting of teaching, and other aspect of a student-teacher relationship. There is ethics pertaining to colleagues. We are not competitive. We are not trying to advertise ourselves. We are not trying to overcome the other teachers. So this also ethics has a bearing. Ethics pertaining to patients, whatever has been discussed, and as regard the NMC or the MCI's ethics are concerned, mostly it relates to patient. Ethics pertaining to assessment and examination of students. Ethics pertaining to research. Ethics pertaining to conduct towards community. These are the overall ethics that we need to address whenever a teacher in the medical college is concerned. Besides being a doctor, he has the additional responsibility of rearing medical students to good doctorship. Thank you. Thank you for the time. I'm again grateful and thankful to all our colleagues from IMA, respected president, past president, and the president-elect, and all the functionaries of the IMA. I am particularly thankful to Professor Ved Prakash Misra for giving me opportunity to meet again and to hearing his lucid and so beautiful talk. And finally, my thanks to Dr. Professor DJ Bora for giving me this opportunity. Thank you.
Thank you, Professor Hota. It has been a very systematic, very well-presented talk that you have given. And it's very important that as medical teachers who are preparing the future generation of doctors and specialists in our country are well aware of the ethical needs they have to fulfill as medical teachers. As a doctor, as a practitioner, they have a different set of ethical goals that they have to fulfill. But as a medical teacher, they have an additional goal, certain additional things that they have to fulfill because they are dealing with impressionable students who look up to them as role models. So Professor Hota has beautifully brought out, and NMC, I must thank NMC for producing such a detailed guideline regarding medical teachers. Previous regulations did have certain points, but no detailed guidelines about medical teachers and medical students regarding ethics. Ethics of the medical students that they have to follow, and ethics the medical teachers have to follow in the relationship of teacher and student. Now it is quite comprehensive, and I'm very thankful that this particular topic has been presented so nicely. And I think as medical, most of us are medical teachers in this or that capacity, it would be very helpful.
You are a failure.
I will tell you one small experience. In the present context, this SDL or self-directed learning is very, very important.
He was the vice president of Indian Medical Association in 2000.
And this self-directed learning, most of our teachers don't know how to do and what to do. So I had a small experiment done. I have produced 10 situations of 100 words each regarding ethical issues, including one that the ideal relationship with a pharmaceutical company and all this, and give it to 10 medical students as a part of SDL to do it. And I am astounded the quality of the essays that they have produced within 1 month. So in all medical topics, first, what are things we have to give in it? And here in 8Com model in ethics, many things can be taught by SDL model itself. So with these words, thanking the participant, Professor Hota, for his very lucid and beautiful talk, so we come to the conclusion of this particular session, and then we can move on to the next session.
So next session is by Dr. Shivkumar Kumbar, our own National Committee on Ethics member. And his topic is medical, legal, and ethical issues in ICU, adult and pediatric. And the chairperson is again our vice chairperson, Dr. Bhavin Kothari. Over to Dr. Bhavin Kothari.
Good morning, all. I am a national president.
Good
Dr.
morning,
Sarat.
Bhavin.
Good morning, Bora sir. How are you? Hope
Fine, thank you.
Dr. Bora sir, chairman of the ethics committee. Dr. My colleague co-chairman, Dr. Menon sir, vice chairman of the ethics committee. Our Indian Medical Association. Our Indian Medical Association National President Dr. Sarad Agarwal, Secretary Dr. Anil Nayak, Past President Dr. Sahajanand Swami, President-elect Dr. Asokan,
He's not talking.
Dr. Ved Prakash Misra, all the Datteswar Hota, all our eminent and distinguished guests, dignitaries. I'm going to introduce Dr. Shiv Kumar Kumbar. And he is not only an eminent medical person of Karnataka state, but he is also an eminent medical person at national level, even at international level. He did his MBBS and specialization in anesthesiology from Karnataka state, and all the multiple academic distinctions he has achieved. He has done LLB special from the Karnataka and also LLM. And he did MBA hospital administration. He did MA journalism also, and several postgraduate diploma like PGD, DMLS, postgraduate medical legal system from Symbiosis Pune, and CCEPC, IAPC, pain and palliative care at Kidwa Institute, Bangalore, and PGDMLE, postgraduate diploma in medical law and ethics from NLSCOE, Bangalore. And one of the very important is CDM, Certificate of Dispute Management. And he's international fellow at UNESCO Bioethics and Human Rights 2022. He was state vice president of Karnataka in 2016. He was chairman of the IMA AMS Karnataka state from 2020 to 22. National level, he was a National Academy Medical Specialties IMA honorary professor. He is IMA headquarter member, standing committee of legal cell, as well as rural health committee during 2020 to 22. He is IMA headquarter member, standing committee of ethics right now. And he is consultant anesthesiologist, medical legal experts, pain and palliative care therapist, and accredited mediator from IIM Institute. So I welcome Dr. Shiv Kumar to deliver his talk on his subjects of medical, legal, and ethical issues of intensive care units, pediatrics, and adults. Welcome, Dr. Shiv Kumar.
Thank you, sir. Thank you very much for introducing me in this way. Next slide. Yeah. Good morning, everyone. Respected national leaders and members of Ethics Committee, Chairman and Dr. Menon too. So now I'm going to talk to you on medical, legal, and ethical issues, especially in ICU. Yeah. We do talk about many times ICU here and there, but what exactly constitutes ICU? It refers to the specialized treatment given to patients who are actually unwell and require critical care medicine, and we have a specialized staff, equipment, and standards. These are called as the ICU. Even for the pediatric intensive care unit, the section of the hospital that provides sick children with the highest level of pediatric care, even to the extent of neonatal care. Many times we come across many places, ICU 24/7 services are available, but this is totally a wrong concept. So whenever ICU is written, it is expected from the public that yes, 24/7 services are really available, and anytime they can rush into the hospital and take treatment in emergency also. At a given point of time, if anybody rushes to the ICU where it is written 24/7, if required things or doctors are not available in a reasonable time, it amounts to deficiency of service, and anybody can file a case on that particular hospital if at all they were written 24/7 ICU services are available, but at that point of time they are not available, and it leads to the misleading and unfair trade practice even in the eyes of the newer Consumer Protection Act. So who are all brought to the ICU? Yes, they can be brought to the ICU in a critical condition from the ward. Whenever they become critical, they shifted to the ICU. Unexpectedly, something goes wrong in the ward, again they are shifted to ICU, and near death in the ward may be expected, unexpected, they are rushed to the ICU, and the post-operative period, again they are shifted to the ICU. Many times we have seen patient brought dead on arrival, but asking for the ICU care. So many times you are in such a situation that you cannot deny unless you shift him to the ICU and declare him dead. So death on arrival, also very, very precarious situation, and we are all experiencing in our practice one or the other day. So what makes the ICU doctors more vulnerable to medical legal problem? Reportedly, mortality rate in ICU is 30%, and this is more than average risk what we treat in the ward. America's statistics reveal that 1 out of every 5 Americans will die in ICU. Figures in our country are not available in this matter. The urgency, the complexity, and invasive nature of the ICU increase the risk of legal exposure to its doctors, including the staff. There is a whole assumption that ICU save the lives, and any injury or a mishap that occurs in the process is unquestionably accepted by the patients or relatives. Friends, it is no longer holds good, because we have to think that every patient is a litigant in the present era. So what are the common allegations that is made against the ICU doctors? Most of the times it is delayed diagnosis in spite of being in the ICU, negligence in medical management, including the complications. There may be a failure or delay in the referral to the higher center, probably ICU from Taluka place, ICU from district place to the tertiary care center, where there may be a delay because of wants of ambulance and so many things. And there can be a medication errors, hospital infections, lack of informed consent, failure of communication to the relatives about the sickness or the gravity of the situation, and prematurely shifting from the ICU and pertaining to the end of life issues which are dealt in the ICU. So Yeah, what are the potential problems we need to be alert, especially in the ICU? Friends, the must be very much concerned about the record keeping or documentation of the patient care, wherein previous speakers have touched a bit of it. Remember, good records are good defenses, and as far as law is concerned, what is documented, what is not documented never happened in the eyes of the law. So what are the qualities of a good record? Good records have to be correct, clear, comprehensive, chronological, and contemporaneous. Incredibly, large number of physicians record only the date of examination and do not think it is essential to record the time of the examination. Friends, many times the time of examination also most important. Time must invariably follow the date. Otherwise, they can land up in deficient service or negligent service. It can be proved in the court of law. Legal terminology always says verbal volunt scripta manenta. It means spoken words fly away, but written words remain. So most of the consumer cases, they rely only upon what you have written on the case paper or summary papers. This is very, very important. So informed consent, I don't want to deal with that. It is a specialized topic itself. So we must be very much know about ingredients of the informed consent. Mere signature and a pre-printed consent form is not at all adequate. And recently, National Consumer has taken it very seriously. And consent should be procedure specific. And there shouldn't be any blanket consent. Refusal of the consent or a denial of consent should be recorded, signed, and attested. Many times we come across the patients who do not accept our services, and in that cases, we must take a signature of the patient or relatives who denied the consent. So nowadays, even violence against the ICU staff, which has become a new epidemic, which I'm going to touch upon for that, and also hospital-acquired infections, especially ICU-acquired infection also, there are a few cases even in a consumer courts. A few allegations, the hospital would need to establish that infection control measures were in place, documented, and they are avoided by the prevention of the acquired infections in the hospital. So communication deficit is always there among the doctors to the patients and relatives. ICU caregivers need an extra dose of communication skills in view of the dynamic changes in the clinical status of the patient. What you see, the parameters of today might change every hour or very next day, and most of the allegations have their genesis in a failure to communicate to the patients or relatives what exactly is happening to the patient, even though it is in ICU, because expectation of the patients or relatives are very much high if fatal patient is in the ICU. What you communicate, you please document it, and what you documented, also you communicate to the patients or relatives to be on the safer side. And establish a good rapport with the family of the patient. Medical legal challenges arising out of end of life care issues and the withdrawal of life support, which I'm going to touch upon you. End of life issues are potential landmines for ICU physicians. We must do something about that. We do not have an unambiguous legal stand in the end of life care issues, but we have certain guidelines from the Critical Society of India. It is now accepted that right to life includes right to die with dignity, as per the Supreme Court judgment. There is no clear answer to the question, is it ethical to limit life's prolonging interventions when poor status of the patient indicates these to be non-beneficial to the patient? Still, it is an ambiguity in all the medical field in India. And many times we do come to a situation wherein a self-designed format for DNR do not. Can you hear me? Yeah. Do not resuscitate on which signatures of the relatives are being taken in a very common and mechanical way. Yeah. Procedure for living wills, advanced directions have now been laid down by the Supreme Court judgments, and strictly speaking, only these would be considered as valid in Indian scenario, especially Supreme Court judgments. Aruna Ramchandra Shambhag versus Union of India and Common Cause versus and Union of India. If you have time, you can go to these judgments. These are really eye-openers. nowadays. Theoretically, passive euthanasia and making a living will or advanced medical directories are now legal in India, but procedures to implement them are tortuous enough to make them impractical. But however, recently, a couple of months back, it has been simplified to a certain extent by the Supreme Court of India. Ethical and legal issues in ICU. In caring for the critically ill patients, it is inevitable that ethical issues will arise because of the complex medical conditions, multiple providers, that is caregivers, that is interdisciplinary specialist or consultant, and very much uncertain prognosis or treatment plans which lead to the conflict and moral distress among the patients. So for this, what we are supposed to do it, we should have a proactive approach in ICU. The conflicts are considered dangerous, no doubt about it. These are the point of litigation among the patients or relatives, and most of the times, 70% of the conflicts are preventable, provided we have a communication skills, empathy and sympathy towards the dying patients or sick patients in the ICU. Burnout, which is a consequence of unrequited conflict. If there is conflicts among our own particular bodies who are treating, yes, probably the primary or the secondary physician, they go into the burnout. And also, if there is a communication deficit, doctor to patients, the relatives automatically goes into the burnout syndrome or burnout, the consequences of which I'm going to tell you. Get to know me. Posters in a patient's ICU room filled by the families. These are very, very important. The posters can be put in the ICUs or the patient bedside, filled by the patients or their relatives, because they will also be very happy to that. Yes, doctors are very much concerned. They want to know from us what exactly we need to tell to the doctor to take care of. Allowing family to be present during the ICU workout rounds by the physicians. This is also a very significant move now. And briefing after the incidents is very, very important. Many times what happens is, if some mishap happens, we leave it to the staff or to the junior doctors or to the doctors, duty doctors to brief the things. This has become a cause of litigation in most of the times, because most of the senior doctors may not have time to convince or talk to the relatives. They push on their responsibility to the junior doctors. Again, it's a delaying among ourselves. Treatment decisions. Yeah, shared decision making is a paradigm nowadays, respecting the patient's autonomy and the beneficence intention of the caregivers. Many times, whatever the doctor says is ultimate. It's a word from the mouth of the God, but it has gone away nowadays. So there is a shared decision making is very, very important, where the patient or relatives also become the party for decision making. Good communication, which I've already told. Key ethical tenets on daily basis. The cornerstones of ethical practices: autonomy, beneficence, non-maleficence, and justice. We need to have family meetings when the patient is very, very sick or towards the end of life. We need to communicate regularly. The mistakes commonly we do is we don't listen to the grievances of the patients or relatives, but we should have a capacity to listen to the patients. And it is proved beyond doubt in a statistic that Indian doctors do not listen, or even if they listen, hardly they do spend time listening to that and responding to their grievances. Provide psychological and spiritual support. Convey to the patient or relatives the uncertainty of the disease. Tell care always continues, but treatment may be withdrawn or withheld at a particular point of time, with all the consensus opinion of the doctors as well as by the patient relatives. The goals of care. Yes, we can propose to the do not resuscitate, do not attempt resuscitation, do not intubate, advance directives and the living will. We must bring to the notice if at all the brain death occurs, organ transplantation options are there. Yes, we can bring to the notice of the relatives. Conflict may arise when a family wishes to continue interventions or want everything to be done, but medical team believes that they are no longer warranted or should not be offered. In such situations, what to do? Again, we are in the dilemma, what to do, what not to do. Again, intervention of the social workers, medical leaders, or the unit head, or surrogate of the relatives can play a very important role. So when you are in such a situation where you are ready to tell them the genuine things, they are not acceptable to things, but because of the religious or the concern of their patient, they would say that, yes, we do not want to disconnect anything. In such situations, attempt to transfer patient to the another caregiver can be taken. Seek adjudication to replace or override the surrogate. You can tell that, yes, bring some other relatives or the people who are really concerned or people who know about the bit of the medical services or their family physicians so that we can have a dialogue with them. Even if it fails, you can involve the institutional ethics and the legal committee guidelines who are interdisciplinary professionals trained in ethics and law. They can intervene and come to the rescue or decision-taking mechanism. Yeah, providing a palliative care in ICU. This is again, it's very, very important topic. And it is not just for the end of life care. I think probably we are lacking in our medical professionals about the end of life care or the palliative treatment. I think Kerala is the #1 in India where the palliative care has started. And even in Karnataka, a few of the states also copying the palliative care therapies from the Kerala model. So withdrawing treatment are considered equivalent. Earlier, there used to be a lot of difference between withdrawing and withholding, but ultimately they are considered equivalent because the goal of both them is same. There is a difference between the killing and letting the patient die. This is very, very important. And many times we come across a doctrine double effect. So this is the one doctrine which definitely safeguards you if something goes wrong. It safeguards you as long as your intention is to relieve the suffering, not to hasten the death. Many times what happens, to relieve the symptoms in the ICU, we may have to use sedative or morphine or any of the palliative drugs, which can have an unforeseen effect when letting to the patient die. So this doctrine of double effect definitely will safeguard you because you have no intention to relieve the suffering, no intention to make the patient to die. So guidelines for the withdrawing life-sustaining therapy. This is also very, very important. Supporting and respecting the family emotionally, spiritually, and showing yourself some sympathy and empathy with patients. It really works a lot. And you are just allowing the death to take its own course, not prolonging it. So when you are in a critical care setup, where the patient is about to die, that time re-examine the clinical orders, remove unnecessary monitors and alarms, because most of the relatives will be looking at that. They are also become technology savvy, assess benefit to the burden ratio, then you decide. Stepwise approach in end of life care is very, very important. Non-pharmacological sleep promotion strategies can be adopted. Control of the oral secretions and humidified air. So, with all having done this, but still there are a hanging sword on the medical profession, acts that concern ICU doctors or wherein the patients or relatives can knock the door of the judicial authorities. They can go to the law of contract or the tort in the civil courts. Doctors can be sued under the Consumer Protection Act 2019, district, state as the national level. A criminal case can be filed under the CRPC. They can complain to the respective medical councils. They can complain to the district health officers. MCI, now it's superseded by NMC, they can complain even to the Human Rights Commission. So the end product of this kind of litigation, apart from going for the judiciary, is the violence in the ICU, which you can say it is a new epidemic in India. So we can come out with this graph. 39.4% of the violence occurs in the emergency wards. There is nothing but the ICUs. Emergency wards and ICU constitute about 15 to 20%, 24% of the violence. So in such a scenario, yes, you should have a provision to take a photograph of the damaged part. Many times you may have to involve the politicians, which is a double-edged weapon, a double-edged sword, and keep a copy of the prevalent acts like medical service persons and medical service institutions, Prevention of Violence and Damage to Property Act of their respective. More than 24 to 25 states in India have got their own acts, but very poorly implemented. Everybody knows about it. So to prevent such kind of violence in emergency or ICU, yes, we have to have a police number, dial 100, which is 24/7, which is recorded. That's most important. Few of the corporate hospitals, they do have bouncers who are paid equally or little more than the doctors also, who can come to the rescue of the hospital staff, most so with the ICU. And we can have a CCTV cameras, not in the ICU, but in the corridor, because patient may be scared because everything will be recorded over there. And make yourself, if fatal such things happen, to save yourself or run away from the scene till the things will get diluted. That's called as make provision for saving yourself. And always get insurance yourself. And again, we are in the mercy of the politicians who have to come out of that. Many times in webinars, you do come across having this deterrent things to safeguard ourselves. Is it practical or not? Again, it's a $1 million question. And we have been struggling through our medical fraternity with the national leaders. What type of action we need? What type of act we need to safeguard ourselves from the violence against doctors? Do we need a modified Epidemic Disease Act? Do you need an independent act for this purpose with a severe punishment? An amendment in Indian Penal Code with a severe punishment. So all three of them are very, very important to safeguard, for which at all angles were pressurizing the central government, but we have got to see how exactly it materialized in the due course of time. Friends, especially medical professionals, those who are working in the emergency department or in the ICU, and all medical professionals in general, who should have medical indemnity policy. We should not practice even a single day without that, because we do not know how the things will turn. So when it comes to the what must be the quantum of indemnity insurance every professional should take place, in my opinion, a minimum professional indemnity insurance of 2 crores for the hospital or the nursing home and 1 crore for the individuals is recommended. So, as you know that there is no limit for the compensation being asked. There is a capping in the consideration for what we pay to the doctors or the nursing home, but there is no capping for the compensation being asked. This is a change which has eye-opener in the new act. So many times, influenced by the insurance companies, are keeping that in a hidden agenda. They ask us to take a policy 1:3, 1:4. It means that if you are awarded a compensation of 10 lakhs for any of the incident, if you are buying insurance policy of 1:4, it means that any one accident, any 1 year. So if the 1:4 ratio, we are indemnified to the tune of 2.5 lakhs only out of the 10 lakhs awarded. So you have to sell from your pocket rest of this 7.5 lakhs. So if at all you have made 1:2 policy, only 50% of that insured amount will be paid to you. Rest of them again you have to pay from your pocket. So I advise every one of you to have a policy 1:1 or any one incidents in any 1 year. It means that if you are compensating, if you have insurance for 10 lakhs, that insurance, whole of the insurance amount will be transferred to the aggrieved party. So you have to be very, very careful by taking this kind of insurance. So many times we come across, can you fix the CC cameras inside the ICU? We have seen most of the hospitals, ICU has a CCTVs, but ICU is like a bloody wrestling court in the machines. It is shocking for late to see what is happening inside the ICU. Better not to injure or put CC camera in the ICU because it's not a social occasion. Patients are entitled to dignity and privacy when in ICU with the suffering. So better to avoid CC cameras in the ICU. Recently, the Supreme Court said hospitals are not a police stations and it cannot direct for installing the CC cameras anywhere as issues of privacy care is involved. So I just brush upon 1 or 2 cases where you need to be extra vigilant. In a Delhi hospital, a central line was put where a jugular vein was injured. It was shifted to the emergency or ICU, wherein National Consumer Dispute Redressal Commission awarded 7 lakhs to the patient, stating that a specific consent was not taken for this procedure, even though patient was in ICU. In one more case, Apollo Specialty Hospital, Chennai versus Muthu Krishnan, Tamil Nadu, wherein proper informed consent of DNR was taken and the doctors are saved, awarding or declaring a compensated amount of 20 lakhs plus 3 lakhs, which was the case in August 2016. In this case, happened a 10-year-old child who was diagnosed with the acute myeloid leukemia and he was admitted in ICU. Chemotherapy twice or thrice was given. Patient was deteriorating. Again, they went for the bone marrow transplant. The allegation of the patient relatives or the father and mother was that no consent was taken for this procedure, that is BMT, bone marrow transplant, and the death was due to the post-BMT complications, and CMC tests were not done, did not give a palliative care. They adopted the DNR, do not restricted guidelines, which was not brought to their notice, and records were not given as per the MCA regulations. And they filed a complaint in the State Consumer Commission, and Commission, looking at the consideration or death of the child, and there is deficiency of the service from the hospital, awarded 20 lakhs compensation plus 3 lakhs mental agony or litigation expenses to the relatives. So doctors approached the National Consumer Dispute Redressal Commission under Section 19 of the Consumer Protection Act. It was categorically studied the whole of the issues, and DNR was signed by the father of the child. Do not resuscitation order was signed by the father of the child, and allegations were not proved with evidence, and the NCDRC set aside the order passed by the State Commission and complaint is dismissed, and there shall be no order as to the cost. So having taken this kind of a consent, that is do not resuscitate orders and very good documentation, so the Apollo Specialty Hospital is saved by paying 23 lakhs. So another one is employing eyes doctors in an ICU is a professional misconduct. As you all know that most of the ICU, what you say in every city, we do employ eyes doctors or non-allopathic doctors. Is it really true? Is it not a professional misconduct? Is it not illegal? Yes, it is illegal because a lot many states as well as the national or Supreme Court judgments are there in this regard. And it violates the Code of Ethics regulations as prescribed by the MCI. And it is a professional misconduct. And there are no ICUs in ICU system of medicine, hence ICU practitioners employed in the ICU is totally illegal. And it amounts to fraud, cheating, and impersonification on the part of the hospital. So we are to reframe ourselves for employing eyes doctors in our ICU. And one more most important thing is, especially in the pediatric is concerned, do not conduct a delivery without a neonatal ICU. It was in Maharashtra, state of Maharashtra versus Dr. Anil Butade decided in 2014, wherein a patient went into the premature labor, at twins delivery, 2 pediatrics were looked after. The one premature baby died immediately. Other premature baby referred to the neonatal center where there is a ventilatory provision. After putting the ventilator, a child on a ventilator, a neonatal ventilator, after 25 days, that child also expired. The allegation was there were no neonatal care unit or a pediatric care unit. Why did they conduct the delivery? Ultimately, the ruling was very, very harsh, and there was a criminal prosecution which should not happen. So, last one is the Common Cause versus Union of India, which is a miscellaneous application in the writ petition, which is very, very important. So, as you all know that Supreme Court simplified the guidelines for the 2 important issues which was given for the care of the terminally ill patients in 2018. These guidelines were impracticable. So recently, the Supreme Court diluted to a certain extent that they can be adopted. A constitutional bench of Supreme Court has passed an order in January 2003 and made suitable amendments to the previous procedure regarding the making an advanced medical directive and withholding or withdrawing of the life support treatment. This landmark judgment is said to be a game changer in the practice of end-of-life care in India, which you do come across quite often in the ICUs. Now, this is a comprehensive law regarding living will and advanced medical directives we can adopt. The key things are, we don't need, unlike previous order or the law, which was in 2018, we just need a signature of the notary or the gazetted officer. There is no need for it to be countersigned by the magistrate. For withdrawing a life support, 2 communities needs to be constituted by the hospital where the patient is admitted. There is no need for the district collector or the DC to be involved henceforth. Earlier, it was under the custody of the DC or a district collector or district commissioner. When the life-sustaining treatment is no longer beneficial, hospital will have to set up a primary board. Then who are the members of that? The members are a treating physician and 2 or more subject experts with a 5 or more year experience. That is enough. That is called as a primary hospital board. Earlier in 2018, the original guidelines prescribed 20 or more years of experience for doctors from the specific specialties, which may not be possible. The primary board will confirm whether life-sustaining treatment should be withheld or withdrawn, and refer it to the secondary board comprising doctors nominated by the district chief medical officer. Every district has DHO or a district chief medical officer or district civil surgeon for that matter, and 2 or more subject experts with 5 or more years of experience who are not the part of the primary board. This is very, very important. So with these 2 committees, we can take a decision whether a life supporting treatment can be withdrawn or withheld. So both the primary and the secondary board now have to provide their opinions within 48 hours of case being referred to them. Earlier, it used to take months together. Ultimately, patients or relatives, they used to take the patient by signing discharge against medical advice. Now it is not the case after this modified law. The requirement of the judicial magistrate to visit the hospital before withheld or withdrawal has been taken away or eliminated. So there is no need for the judicial magistrate to come to the hospital and inspect it. This is again a very good decision by the Supreme Court. So with this, I think I have not overshooted my time, which is allocated to me. Thank you one and all.
Dr. Bhavin?
Thank you everyone.
भाविन भाई अनम्यूट करो आपका स्पीकर.
Yeah.
Thank you very much for covering a very nice and new topic, Dr. Shiv Kumar ji.
Thank you, sir.
Vulnerability, you showed very well the vulnerability of emergency care person and ICU care person. And you again establish a very good how to keep the record, which is very important, how to keep the communication with the patient, which is very important. And new topics like euthanasia and organ transplantation and discontinuation of terminally ill patient. You showed it very well, how to handle the violence. So with the era of this new intensive care unit, it is going to increase tertiary care and emergency care. So you showed an importance of this subject, and thank you very much again for elaborative the.
Thank you.
So it has been a very, very illuminating talk, and I really congratulate the presenter. And he has done a wonderful job of presenting all the aspects so that the listeners are well aware of the complexity and the scope of the problem. In pediatric ICU, in neonatal ICU, in general ICU, what one has to do, what steps has to be followed, everything he has recounted very well. And this is an eye-opener. Dr. Menon,
Yes, sir.
in our publication, I think we can make this as a pamphlet.
Yeah, definitely, sir.
And it will be, I think, very helpful for all the doctors. And we can make it available online and as well as offline also. So if you will care to write your lecture.
Yeah, I'll do, sir. Yeah.
Very, very happy.
Okay, Shivakumar sir will do that. We'll publish it.
Sure.
Sure, sir.
So let us go to the next topic.
Yes, sir. Next, the final topic will be more interesting. It is the do's and don'ts in medical practice, and the faculty is our Professor Dr. Nilesh Parekh. He is our own committee member. He is an ophthalmologist practicing at Medical College Bhavnagar. He is a professor and head of department there. He has been a faculty for medical ethics and related topics at various forums, CMEs, etc. And he was the Dean Medical Faculty at MK Bhavnagar University in 2010-15 time. He was a member of Medical Council of India 2013 to 17. He is currently a member of Gujarat Medical Council and Ethics Committee of Gujarat Medical Council. He is a member of the Ethics Committee of World Medical Association from 2023 to 25. He is advisor to Gujarat Public Service Commission and Jammu and Kashmir Public Service Commission, assessor of MC and NMC, NABH and NBE. And we are happy that he is going to talk to us on do's and don'ts ethical practice. We have already heard the importance of ethical practice in our profession, and the 4 pillars of medical ethics: autonomy, the beneficence, non-maleficence, and justice. Everything is highlighted by most of the speakers so far. So there are a lot of things which we should do and which we should not do as in our profession when we follow the ethical lines of practice. I think we will hear from our Professor Dr. Nilesh. Dr. Nilesh, please.
Good afternoon, everybody. Thanks to the National President, the HSG sir, Chairman sir, Dr. Bora sir, Dr. Ved Prakash Mishra ji, Dr. Jayalal, Dr. Hota sir, Dr. Shiv Kumar sir, Girish Tyagi sir, Bhavin Bhai, Menon sir, and it is always good to be connected with Bora sir and Aaron sir. with whom I share a special bonding during my MCI days. And today I will be talking on do's and don'ts in medical practice. Since I am the last speaker now, I think some of the things which I was to mention have already been covered by the previous enlightened and learned speakers. But I will restrict my talks to some very simple, common and basic issues which we encounter in day-to-day practice and where we like falter and make mistakes or errors. So I'll try to draw the attention of the delegates to those things. And I will also talk a little bit about some disrupted relationship which needs to be set right. And so in the end, there might not be a new message, but I will still cover all the important things for daily routine practice. So I'll just begin my presentation. So we come to the first and the most important relationship, which is the doctor-patient relationship. And as we know that a healthy doctor-patient relationship is most essential and vital for any successful and meaningful medical practice. Nowadays, as we know that there is a breach in the trust and faith, and without faith and trust, no relationship can sustain. So let us all try to restore the trust between the patient and doctor. So what we can do for that? First of all, we need to be a good listener. Listen to the patient without any interruption, and that itself will make the patient feel much, much better once we have heard all his complaints. And at the end, always ask if there are still more queries, or some of his queries have not been answered to his satisfaction. Try to answer all the queries. Sometimes we may feel that his queries or concern are totally irrelevant or very trivial, but still we need to address to it. Always show empathy, compassion, and concern for the patient. And give enough time for consultation. What not to do? Do not insult the patient or the relatives. Be courteous and be polite. Many a times we see that the patient is trying to tell about his complaints and the doctor is already writing the prescription. So let us all give enough time to the patient and we not to insult the patient or the relatives. Do not use fancy jargons or complex medical terms, but talk to the patient and relative in easy to understand, simple language. We want to avoid at all cost violence against doctors. And to avoid this, we need to set the doctor-patient relationship right. There is a small video for an ideal doctor-patient relationship. We can go to listen to it, and it beautifully explains the ideal doctor-patient relationship.
audio.
No voice.
Nilesh, your video is not having voice.
Nilesh bhai, there is no voice.
Voice nothing. Yeah, we are trying to fix it, sir.
Stop sharing and share again. There is an option share with audio.
Okay, sir.
First stop sharing, sir. So now share. There is an
Yes.
option share with audio.
Here to be the last speaker. There's very little time left. So I was inspired to sing, which I shall sing before you, which carries the essence of doctor-patient relationship, which we have to bear in mind. I have Dr. Parikh here, and he bears me out that Dr. Ambrose Pare, in the 16th century, he gave a great quotation, I dressed the wound, God healed the wound. I dressed the wound, God healed the wound. So God there. And till today on wound healing we know nothing except the fact that God heals the wound. So allow me to sing for you, and I'm sure you can join. Mareez means a patient. मरीज की मुस्कुराहटों पे हो निसार, मरीज का दर्द मिल सके तो ले उधार, मरीज के वास्ते हो तेरे दिल में प्यार, डॉक्टर इसी का नाम है. We doctors are expected to be well dressed, but never too well dressed, because it intimidates the patient. There is a conversation in New Journal of Medicine where a patient tells the doctor, doctor, I am afraid of you because you are too well dressed for me. So we are supposed to be voluntarily poor. माना डॉक्टर देखने में फकीर है, फिर भी यारो दिल के वो अमीर है. माना डॉक्टर देखने में फकीर है, फिर भी यारो दिल के वो अमीर है. मिटे मरीज के लिए वो जिंदगी, करे मरीज के लिए वो बंदगी. किसी को हो न हो हमें है एतबार, डॉक्टर इसी का नाम है. A patient comes to us not by walking, not in car, not on cycle, but on a path of faith. A patient comes faith. Faith. रिश्ता है मरीज के एतबार का, जिंदा है तबीब से नाम प्यार का. You know one thing I tell you, somebody in distress, you look at the person as your own, and if love is dripping from your eyes, much of the patient's illness is likely to be mitigated. We must look at the patient. It's I who am suffering. It's I. It's incidentally. In fact, in Quran it is said that before a doctor goes to a patient, he must thank the God that but for your mathematics, I could be there and the patient could be here. Please remember. रिश्ता है मरीज के एतबार का, जिंदा है तबीब से नाम प्यार का, कि मर के भी मरीज को याद आएंगे, मरीज की आंसुओं में मुस्कुराएंगे, कहेगा हर मरीज मरीज से बार बार, डॉक्टर इसी का नाम है।
बंद थी ना।
Happened to be the
So for the doctor-patient relationship, as we know that most of the issues we face today are due to a disrupted doctor-patient relationship, and all of us should try and restore that relationship immediately. Another issue or another relationship is the doctor-doctor relationship. Here also somehow lot of problems are coming up nowadays. Maybe it can be attributed to the greed, selfishness, the feeling of competition to prove I am the best. So let us all first resolve that there should be no medical jousting. We should never speak ill of our colleagues. We should always avoid unnecessary discussion in front of the patients. Many a times working in the ethics committee, we have seen that a small negative comment or a remark by a colleague will spark a confrontation between a patient and a practitioner. So let us never criticize our colleagues. We are all in the same boat and we all need to work to restore our doctor-doctor relationship also. So let us remember the 3 monkeys of Gandhiji. And nowadays the 4th one, no evil on WhatsApp also. Another daily day-to-day activity is prescription writing. All of us know about prescription writing, but the thing I want to highlight is always write legibly and in block capitals. The 1.5 is the this ethics code corresponding to it. Sometimes because a difference in A and O can change the whole drug, and the patient can get something else and you have prescribed something else. So my request is to please write legibly and in block capitals. And always write your registration number in your prescription along with your name and signature. There is one more thing, is do prescribe drugs in generic form only. Why? Let us see. Suppose you prescribe a drug called Medzol. This drug, this Medzol trade name in different parts of the country is available as 5 different drugs. Now what happens if you have not written it in the generic form? What will happen? Your patient can get anything and it can lead to disasters. So even if you want to write the pharma name, you can write it into brackets or you can write the trade name into brackets, but always write the generic name first and in block capitals. We have seen many errors in medical certificates working in the...
Namaskar, Bola, Prashad. Good.
So,
Anji.
Always give the medical certificates as per the pro forma prescribed by the Medical Council of India or the NMC only. We will also have a look at the pro forma also. Always give certificate according to your competence and qualification level only. Do mention your registration number along with your sign, name, and qualification always. Like this is the pro forma, which starts with the signature or identification of the patient, is identification marks, and the things. This pro forma is available in the MCI ethics booklet also. Don't issue certificate in absentia of patients. We have all come across cases where the patient was involved somewhere in a crime scenario, and here we have the doctor has issued a certificate that he was under his treatment and was indoor, and a lot of issues have arose because of that. So never issue certificate if the patient is not produced before you. Don't write not valid for court or MLC purpose, because some of these certificates have actually gone to court and the honorable courts have taken it very, very adversely. That how can you write not valid for court or MLC? You are obstructing the fundamental right to justice of a patient. It is for the court to decide whether it is valid in court or not. It is not for us to decide whether it is valid in court or not. Another problem in today's era is about the doctor-pharma relationship. So never trust this person. He will always get you into trouble later on. So please be aware of this person always. So what not to do for pharma and health or other allied industries, what not to do. No gifts, no travel facilities, no hospitality of any kind. And now what are the sanctions? Suppose a practitioner is caught or found guilty of this, what punishment can be given? The gift is from 1,000 to 5,000 rupees. He can be censored. From 5,000, removal of name for 3 months. 10,000 to 50,000, removal of name for 6 months. 50,000 to 1 lakh, removal of name for 1 year. And more than 1 lakh, removal of name for more than 1 year. So again, let us all restore our ethics and be very, very careful while dealing with pharma. As already told by a learned speaker previously, there is a little provision of taking a gift up to rupees 999. Another important issue in day-to-day we face is about medical advertising. The code of ethics is very strict on advertising, and we have seen a lot of unethical advertisement every day nowadays. So let us all summarize the code of ethics on medical advertising. When and how can a practitioner advertise? On starting the practice, on change of type of practice, on changing the address, on temporary absence from duty, on resumption of another practice, on succeeding to another practice, and public declaration of charges. So thank you all for your patient listening. And I just tried to cover some common topics. Thank you so much. all for your patient listening. And thank you, Bora sir, Menon sir, Aaron sir, Ved Prakash sir, and everyone. Thank you so much.
Thank you, Dr. Nilesh Parekh. That was a very crisp and clear presentation. And the message is clear regarding the doctor-patient relationship or doctor-doctor relationship, writing prescriptions and medical certificates, pharma company relationships. Everything is very clear, and we have to stay ethical and stay safe. That is a message. So I think we are running out of time. So I think we will go on to the discussion part of it, because there will be a lot of questions to the speakers. Only doctor, I think Dr. Shikumar Kumbar has left because he has got another seminar going on. So he is not there, but all others are here. So Chairman, we'll start the interactive session.
Successfully complete and so beautifully complete today's program, and 5 eminent speakers have spoken so well on their assigned topics that it has been a really, really very enriching Sunday morning for all of us. In this series of ethical questions, we need to also approach newer things. For example, one of the very important things that is coming to the realm of health and medical care is the use of more and more use of artificial intelligence. So with the use of this, what are the different areas where it can be used? And with the more and more use of this, what will be the role of the doctors in this entire process? And third and most important, what new ethical issues it will present? This is very important. So in the next, we will try to focus on this very important topics, and I would like to have your suggestions on the different topics that we need to discuss. So now I think it's open for questions, and Dr. Menon will run the question and answer session.
Yes, sir. We have one question in the chat box. Does NMC entertain third-party complaints against the government doctor after the State Medical Council dismissed the case? It's from Dr. Sugunakar from Dr. Sugunakar Raju. I think the Pesha sir can answer, or Chairman. Whether NMC will entertain.
I myself,
Can you please
personally, I am not very aware.
Yeah.
Okay, I'll read the question once again.
Yeah.
NMC entertained third-party complaints against the government doctor after the State Medical Council dismissed the case.
I think this is a very tricky question from that point of view. As I told you about the guideline of the professional ethics of doctors, it is yet to come. It is in the process of making. But what I can understand from the question, if there is a third-party allegations or case against a doctor which has been dismissed by the State Medical Council or SMC, it can be taken up by the NMC. In fact, there are forum, this is one forum, the second forum is NMC. So obviously there is always a possibility the NMC can entertain, but the State Medical Council's ruling or whatever opinion the State Medical Council has given will have a bearing on the decision of the NMC.
Okay, Mr.
See, Dr. Menon, yes. I will just add to what Dr. Hota is putting across. He's right. I'm just referring to the existing guidelines which are in vogue. See, this is very clearly prescribed. the trying jurisdiction on a registered medical practitioner continues to be with the state medical council where his or her name is included. Therefore, trying jurisdiction cannot be directly taken up by NMC or any authority. There are 3 levels which are prescribed in the Code of Medical Ethics itself. First trial is expected, even if the NMC has received any complaint, it has to be referred to the concerned state medical council where the registered medical practitioner is registered with. The matter is required to be decided in a period of 6 months. In case the matter cannot be decided in 6 months, the reasons have to be recorded as to why the delay is there. And in case the 6 months the case is not decided, then the aggrieved party can prefer an appeal even without the decision of the SMC again to the NMC. And in case NMC finds that the delay was not condonable, it can take up the complaint even without the adjudication by the SMC. But the normal course is any party which is aggrieved by the ruling which has been given by the SMC, State Medical Council, can appeal within the stipulated period before the NMC. And not only that the NMC decision is last, anybody who is aggrieved by the decision of the NMC, either party, can then approach the Ministry of Health and Family Welfare, which is the appellate authority against the ruling given by the NMC. So there are 3 levels. Primary level is State Medical Council. First appellate authority is National Medical Commission. And over the decision of the National Medical Commission, Government of India through its Ministry of Health and Family Welfare is the appellate authority.
Thank you, sir.
Professor Misra, just I would like to add a little. Yeah, please. Please, sir.
Dr. Beji has properly laid down the procedure, and as of now, that same procedure stands.
Yeah.
In place of MCI, only NMC has come in.
So if I may be permitted, I would like to add a little more thing what is in the making now.
Yes, please, sir.
Yeah. So this is UID is coming for all the registered medical practitioner. It is mandatory that all the medical practitioner has to have a UID from the NMC. Now, when this NMC will come into force, one doctors can have practice in all the state of the country. And that will create a little bit of, deviation. It will bring a little deviation as regard which state medical council will take up the matter. So that is what is coming up. Nothing is clear yet. They are formulating it at NMC level. That is in the making. That is what I wanted to say. I fully agree with.
Dr. You are right. The notification which has been issued, it's contradictory within its own self.
Yeah.
You are referring to clause 4. You look at clause 6 of the very registration. It talks of that it will be referred to the state. You can apply to more than one state, then the transfer of registration. So that regulation is contradicting itself from, you are referring 4.3. It is contradictory to 6b.
6b. Sir, what I want to add, I fully agree with you, sir. The system of State Medical Council, NMC, and the Government of India Health Department. These 3 tier of appeal.
Correct.
Primary appeal and secondary appeal. That is what exactly the situation at present it prevails.
Probably after the registration, new registration, I think the place where the doctor is practicing, that medical council has a say, is it not, sir?
Yes, sir.
Thank you very much.
Sir, here the problem will come. As the health is a state subject and medical education is subject. If NMC is taking up all these registration, and definitely what Beth sir have told that they are giving option in which state they have to practice and they have to give one, because this unique UID was, if sir you remember, it was this DMPP project, which were in our time, which was under making. And that will make, I think, things very clear. Otherwise, it will be very haphazard.
Rajan, that has been provided in the new registration regulation in regard to prefix and suffix in case of the transfer. But unfortunately, that the regulation which has been notified itself is plagued by n number of contradictions. And moreover, just to add on it, under the NMC Act, the trial jurisdiction is to be provided by a separate regulation. Because now there is a added on entry. If you look into, again, if I'm not using the taxing, if you look 57.2 and a subsection ZD to it, there is a regulation which is required to be prescribed in regard to the disciplinary jurisdiction or disciplinary proceedings against RMP, which is not included in the present registration regulation, because there is a separate regulation which is required to be issued on the said count, and that has not been notified as yet. It has not been even put into public domain for comments.
Sir, I would like to know a viewpoint from the wisdom of all the participants. In fact, I raised this in the last NMC meeting. As has been pointed out, sir, it is a contradiction, very correct, but it is in the public domain. We can always give our viewpoint, and particularly IMA should always give a viewpoint on this very clearly. Second thing, what I would like to know from our learned Professor Misra, who is always a guide to me all along. Well, the next is coming. Kindly hear this so that you can give a guidance, which I raised in the meeting also. In the next, the exam will be conducted in the final MBBS, the theory part. Now, in the theory part, they have multiple choice questions on 7 subjects. A lot of deliberation took place, but the fact remains, if this is almost an encroachment into the domain of university.
100%.
Yeah.
Education, yes.
I did. So I think with the IMA should write about it. I have raised my objection in the forum. See, unless the university conduct the examination, how can it give a certificate? So then the second question which I asked, sir, am I given to understand that the central act supersedes the state act? No, it is never. See, notwithstanding to anything, it is very clear that any act should not have an or superseding or contravening effect on the other act. So that's the reason I have raised this. Let IMA take up the issue. I will just suggest. And in fact, in the meeting also, many people were of the opinion that IMA, as an independent forum and the largest professional body of the country, should take up this issue and raise this issue before the NMC authority.
Frankly speaking, IMA had already constituted 2 standing committees under my chairmanship. We have given detailed report in regard to next. We have given detailed report in regard, and that has been made known to the NMC and to the Government of India as well. Dr. Ota, I will send the copies of those 2 reports with detailed analogy, including the point that you have referred to. I have straightway said, what are they talking of Central Act? Where is university defined? The word university is defined under the University Grants Commission Act under Section 2F, read with Section 3.
Yes, sir.
Is it a state act or a central act? You see, even NMC Act. NMC Act talks of the definition of the university as what? University means as defined under Section 2F of the UGC Act.
Right,
therefore, a university is the creation of the UGC Act under Section 2F with the entitlement to confer the degree. Right to confer the degree is exclusively based on the assessment by the university by examination conducted by its own.
Yes,
therefore, there cannot be a neighborhood who will be creating a portion on the basis of which university will be creating a degree. So that is a fundamental issue. I mean, it's a larger issue. The central enactment that they are talking, they will have to then say there has to be a clause, notwithstanding anything contained in this or any other central act.
Sir.
Then it will prevail.
But this is in the making. I thought I'll bring to the knowledge of
all these details, Dr. Hota, I will forward both the reports to you. They have already been worked out, and IMA with a covering letter has put it across to all concerned, including NMC.
Yes. Perfect, sir. Perfect.
Beji, please send to me also.
Sure.
Dr. Ravindra Reddy, you want to say something?
And meanwhile, one more thing, that as a health is a state subject and education is a central subject, but if it is in only concurrent list, then only Central Act can supersede on the state subject. Otherwise, it is not.
Rajesh, medical education is in the concurrent list.
Concurrent, yes.
It was on the central list, but by amendment of 1979, it is in the concurrent list.
Concurrent. And sir, state medical councils are formed by the Legislative Assembly Act. And all the states are having different act. So, and when the practitioner is registered with the state, then they have to be trialed by the state.
Look, there are contradictions. The argument is double-edged. See,
and I remember
the code of medical ethics prescribed by the MCI and the NMC. It's a central regulation.
Yes.
The state medical council does not regulate on the code of medical ethics. So there you are accepting a central act or a central regulation. But you're right. No, regulation is a subordinate legislation. No subordinate legislation can override the impact and effect of a primary legislation. State councils are created by the state enactment, and therefore that cannot be done away with any provision which is there in any regulation issued by anybody, as it is a subordinate legislation. So it is a very core constitutional question, which of course, in case things are not agreed upon, the courts will have to take a call and decide the matter.
Ready, sir. Ravinder, sir.
Sir, my question is, once a state medical council dismisses a complaint, as per the latest NMC regulations, patient cannot go for appeal. It is only the doctor who is punished guilty can have a right to go to appeal to NMC or Ethics Medical Registration Board, EMRP. Patient does not have a right. Is it true? It has come in the when draft regulations has come, we have gone through it.
See, again, Dr. Reddy, we are a bit. See, the regulation which has been notified, as I told you, if you look at the entry of the subjects on which the regulations are to be prescribed, the Code of Medical Ethics is covered under 4 sub-clauses. The present registration notification is under 3 sub-clauses. One is missing. What is that missing clause? That clause is ZD. That ZD contemplates issuance of a regulation by the NMC in regard to the disciplinary jurisdiction of the councils. So that notification is not yet out. Therefore, to say that State Medical Council once has decided the matter, frankly speaking, no authority will have any jurisdiction of inflicting any punitive mechanism without provision for an appellate authority. This is what is called as the general principle of law. If the State Medical Council has got a right to try, the aggrieved party will always have a right to appeal. You cannot have open-ended appeals. Like there cannot be any appeal over the judgment of Supreme Court other than the review petition. But there will always be the state medical councils per se cannot be the end decision maker on a matter pertaining to invocation of disciplinary jurisdiction. There will always be an appellate authority which will have to be created because that is the requirement of law.
Okay, sir. Thank you.
Another question now. It is regarding a patient with no bystanders or relatives. There is nobody to give consent. So how to proceed in that situation? Consent. Nobody to give consent. So how to proceed?
I think it is an incomplete question in the sense that for what? Consent is not required for a regular medical advice. Only information is to be diverse to the patient. So only when a question of interventions or surgery comes, then only the consent is required. And secondly, I may be subject to correction. Informed consent is from the patient himself for examination. For that, we do not require anybody other than the patient for the consent. But if we are going to have an interventions or a procedure, obviously we need to have a witness and preferably a relatives. Sir, any addition, sir?
No, I think absolutely right. See, informed consent, consent, consensual consent, non-consensual consent. These are all the various types, but you're right. Until and what is the situation where you are required to be having a consent? In case of an emergency, an unconscious patient, absolutely brought by an alien. So the requirement of consent in case of an emergency care, requirement of, there are different. So there are different natures of consent. I mean, we can have an independent talk on consent itself,
sir.
but we will be able to elaborate it situationally.
Okay, sir, thank you very much. Then there is one more question is how to, in the case of multi-systems involvement, general view of responsibility of patient is always questioned. What is the right path in this case? Multi-system involvement in ICU, probably that is what he meant. Dr. Rangarao, whether you can ask the question direct, you can ask. Dr. Rangarao is here.
Dr. Menon, can you grant me an exemption? I have another commitment to keep at 1 o'clock. I was to join.
Definitely, sir.
My regards, sir.
Good afternoon, my regards to everybody. My regards.
Good
afternoon, sir. I'm Dr. Rangarao. Thank you.
Yeah.
Thank you, sir.
Sir, good afternoon, sir. I'm Dr. Rangarao.
Yes, please ask your question.
Yeah, so generally we encounter this sort of issues. No, many a times the patient is been admitted by one department, and the patient lands into multi-departmental, multi-system issues, and then one after one they want to disown the patient. In these circumstances, everybody comes on to the administrator and asking what to do, and who has to take.
Professor Bora, can I take up this question with permission?
Please, please.
Very genuine concern. In fact, this happens in almost all the medical colleges. It's a very common scenario. I go back to my PGI days where we had a very nice system. If it is multi-department involvement and it requires multidisciplinary approach of a critically ill patient, in that case, the admission is for all the department. In the ICU, the patient is admitted under all the departments, concerned department, related department. So after back to my state, what has already been rightly pointed out, I find that there is always a reason for the treating physician and surgeon to escape from that patient. How to get rid of it? The writing is no intervention required. On the paper, they will write down no active intervention required. And they wash their hand. That is how the system proceeds. This is where it cannot be individualized. It has to be institutionalized. The head of the institution has to bring out a notification that any patient which requires multidisciplinary treatment has to be admitted to all the disciplines, whether it is ICU. Therefore, the discrimination will come. Suppose somebody has a head injury along with chest injury, along with pelvic injury and all those multiple injuries, polytrauma. In that case, this patient should be kept in the trauma ICU, which is an ICU, one ICU where all trauma patients are admitted. And this patient should be admitted to all the discipline that requires attention of the patient. This is what should the policy. Each institution should have their guideline on this.
Great. I think that should answer the question. Thank you, sir. Dr. Niraja Agarwal asked if one patient is referred from one hospital to a higher level hospital. Sometimes that higher level hospital offers some money, some commission in the form of consultation. Can you please comment? Absolutely no cuts and commissions. I think there is no need for discussion. This also what, sir?
Sir?
Cuts and commissions.
See, there is a beautiful word coined for that. Referral. It is not commission. You know, yes. This is practiced in most of the metropolises. And it is really painful and disheartening to mention that there is a system exists in most of the metropolises the culture of family physician and where the referral comes. Anyway, besides white only patient referral, even investigation, we are all aware about it. So cuts, the next word is cuts, not commission. So we have to coin some beautiful term for that, but that is extremely unethical. No official body is of approval of that. Even all these professional bodies are not in approval of that. So this is a question not to be kept in mind. Whatever is being done is not an ethical practice.
Exactly, sir. Many times, many politicians and media comment very bad about medical professions. How can they be challenged?
I think Professor Bora can mention about it.
The
media victims.
question
The word is media victims.
See, it is very bad situation as it is raining just now because of multiplication of medias and each trying to overdo each other. So they are actually falling behind the doctors and trying to find faults because they make a very good story for them. But it may, many cases, these are very wrong stories. And what I would suggest that doctors should be very cautious about media, and they should also learn how to deal and handle various platforms available in the social media. Beyond that, I think it's very difficult to say. There can be question of legislation, but I think that is also too premature at this moment.
Okay, sir. Okay, sir. Then there is another question from a resident doctor. Resident doctor is liable for medical negligence, ? And if yes, what type of indemnity insurance he should take? What is his liability and how he should insure himself? That is a question. Resident doctor.
I think the doctor from the iPhone wants to speak, but he is mute.
Who, sir?
He is speaking, but we are not able to hear, sir. Kindly unmute. We try to unmute.
iPhone.
Yeah, now it is unmute. I have done it. But
Is it?
But still not audible.
I think he may not be addressing us.
But we are focusing on him. Anyway.
I think a resident doctor's question, sir, whether how he should be insured. Is he liable?
Dr. Iron.
Iron, sir, can you answer?
Which question, sir?
A resident doctor.
Resident, yeah.
Is he liable for medical negligence, and if yes, what type of indemnity insurance he should take? Resident doctors, are they liable?
Yeah, sir, because the resident doctors are working under a professor. So definitely the primary liability is of the resident, but it is a concurrent liability of the professor also. So I think in the present scenario, he should also take some indemnity insurance. Because the court may decide anything, because the consumer courts are giving so much of opinion and judgments which are coming out, and he may be kept liable. So I think he should take the indemnity.
They can also go for IMA's professional protection scheme. It is there.
Yes. I think that is the best one. This IMA professional protection scheme from Kerala is very good. Very good.
The national level also it is there, sir.
National they have started. Yes.
Yes.
I think
it is there.
We should take it. And if permitted, then I can add about this media, because in media it is very, very balancing act. just like we are walking on a rope at a height, because in media we can't avoid them, and we can't love them, we can't hate them. We have to keep things very, very diplomatically, and we have to give our opinion, our answer very, very short and sweet. And here the IMA have one major role, and the local IMA should work as a trade union, and they should decide a common line, because the problem arises because the local media approach the doctor for this advertisement and all these monetary gains and all these things. And if they are refused by some doctors, they try to target them, and they take up some false cases or some these sort of cases. Recently, one case happened at Jaipur, where this seizure was shown after this cardiac surgery, and that seizure was of some local seizure to used at the funeral for cutting this ghee and all these material, and that was taken and that was published in the Bhaskar very, very prominently. So here I think IMA should work as a trade union, and the local IMA should decide how to handle these, and this will be better.
Thank you, sir.
So regarding the resident doctors, they are also registered medical practitioners.
Yes.
They are registered with the state medical council. So the council may decide on the issues of negligence and may hold them responsible also.
Yes. There is another question. Can the doctor refuse to take a non-emergency case if the patient demands 100% guarantee of cure? Yes, you can refuse, I think. Any more comments, sir?
Can you please repeat the question?
The doctor refused to take over a non-emergency case if the patient demands 100% guarantee or cure. You can refuse.
I would like to know the viewpoint of all the esteemed members present here. The right to refusal of a non-emergency patient by a doctor.
Yeah, the doctor has a right to opt for his patient if it is not an emergency, not an emergency.
What is the present viewpoint, legal viewpoint? Non-emergency case, refusal by a doctor. Right to refuse.
See, a doctor has got the right to refuse a non-emergency patient, but he has to do certain things. He has to record writing, and secondly, he has to refer the patient, to guide the patient to some other doctor. That is, I think, this is the basic requirement, or otherwise he will be failing. He will be, I cannot take up your case, but I'm giving you the address, phone number of so-and-so doctor who may be able to take up your case. So I am giving you this.
So he insists that you have to see me, and he becomes really hostile and start behaving badly. I'm coming to that situation. There are many places where we have come across a situation. No, I have come to Professor Bora. You have to treat. I am not going to anybody else.
You have the right to refuse, sir.
Sir, there are conditions which are laid down in the Act, that only in emergency you have to tackle the emergency, otherwise in non-emergency cases, and in this case the patient is demanding 100% cure, and it is in the Act written that you can't assure 100% cure. So it is out of the question that patient is demanding so undemandable thing that it is not possible. I can't give the 100% cure, and so you have a different choice. You can go anywhere.
Dr. Aaron, I am giving a different scenario altogether. You know, the patients are given appointment by your private secretary or the receptionist at the hospital.
Yeah.
You do not know who are the patients who have come.
Okay.
When you start disposing one after the other, you find that the one person that who has come, he has high expectation from you, but you find that this patient is going to be a troublemaker for me for the rest of the life. Definitely you would like to avoid, but he insists upon.
Definitely here, sir, we have to play diplomatically. And what I will say one of very senior surgeon. I think at present he is no more. He practiced in Nimach, where I do, about 40 or 50 years back. What he used to say, that the dying patient is not the patient of Dr. Bobra. He was the Dr. Bobra. जो भी patient मर रहा है वो मेरा नहीं है. So in this patient, yes, appointment is given. You see the patient, you do your best, you give your best opinion, and after that politely tell him that it is better to get a second opinion, and you can go to some more senior doctors or some other colleague and take second opinion also and decide yourself, because it is autonomy. It is autonomy.
That will be ideal.
And it is Dr. Menon to refer. He is
Fine, sir. Fine, sir. Some states allow private medical doctor to prepare an MLR. Some don't. Is there any guidelines from NMC?
What is the question, sir?
Some state allows private medical doctor to prepare medical legal register. Example, Haryana. Some don't. Example, Rajasthan. I think every private doctor has a right to prepare a medical legal report, I think.
No, as regard medical legal reports are concerned, it is perfect. You know, the primary surgeon or the physician who attend the patient with medical legal report.
Yes.
He has a right. But there is one issue, different issue. Those who are with me in MCI also, my good friends. See, but the post-mortem is not permitted to the private hospital most of the time, barring very few.
This please mute, please.
The post-mortem examination has not been permitted in most of the private hospitals, barring very few. If I remember correctly, only 2 or 3 were permitted by the state government, by the Home Department. Otherwise, no medical college, private ones, has the authority to conduct post-mortem examination. And that is the reason. That is the reason. If you look at the postgraduate department of forensic medicine and toxicology, they are almost disappearing from private medical colleges.
Okay, that's the point. Thank you, sir. If a doctor practices in more than one state, how is it possible? I don't know. He should be registered in all states. A doctor practicing in 2 states, like maybe in the northern part of Kerala and southern part of Karnataka, there are some people crossing the boundaries.
You know, there are wandering surgeon, physician, and all sort of professionals. They are wandering. You know, they have a van with all the instruments. And in fact, that is a practice that is going on. But at the same time, that now that new UID is coming, I think that is going to give the permission for the doctors to practice anywhere in the country. For that matter, with the registered medical practitioner, one can always practice anywhere till date also. But when it comes to a medical legal or a consumer protections comes into the problem, then only this thing arises. Otherwise, everybody is practicing in every place possible across the state.
The thing as it stands as of now is that a doctor who is registered in one state, if he wants to practice in another state, the state medical council may require him to register in that state. For example, hundreds and thousands of doctors go for their residency to Delhi. And Girish Tyagi insists that everyone should be registered in Delhi Medical Council. And they do. So this, and if they go to Rajasthan, they may have to re-register again. So this is there. This has been going on. But with the unique identification, possibly that will be no longer there.
Okay, sir. Okay. There's another question, can a government doctor be charged for medical negligence? And if yes, who is going to give the compensation on behalf of the doctor? Is it the government?
You see, they had exempted most of the government medical college from the CPA. government hospital from the CPA. That the reason we don't have many cases, consumer cases against the doctors in government hospital. But the fact is that it is only confined to CPA. If it is criminal negligence, okay, the doctor can be prosecuted. This is my knowledge. Any addition?
Yes, civil and criminal negligence, they can be prosecuted,
Yeah.
but not CPA.
Okay. With the teleneurology, it's common to practice pan-India. How will the law work then? It's a teleneurology, telemedicine is a different topic. I think we will not go into more details now, and we are running out of time. If I think if somebody can take up this question, we'll finish after this.
Which one, sir? Possibly I am a little hard of hearing.
Teleneurology.
Teleneurology.
That is as good as telemedicine.
Achha, so telemedicine.
Yes,
I think a lot of development has taken place in telemedicine. It is being practiced very, very rampantly now. And particularly for the COVID, government made it a policy to have telemedical service. So with the approval and endorsement by the government, when the telemedicine service is being provided, I don't think there is any problem. And there are a lot of schemes both by Government of India and also by state governments, where this telemedicine service is encouraged. For that matter, SCB is one of the nodal center for telemedicine where I was working. We are connected to all the district headquarters hospitals, to the subdivisional hospital. Now the steps are being taken to connect them to the block level, to the PSC and CSC level. So this is an acceptable modality. And as regard this is concerned, this is only medical services. Only medical services.
But sir, during the pandemic, it was relaxed, but I don't think it is going to be so easy. There will be more stipulations coming up. Even you need to have some training on this.
I will also add, sir, NHM has already come up and it is already established a scheme. The scheme has hub, then spikes. This is already officially accepted by Government of India through the NHM. So I don't think any problem with this telemedicine service, as long as it is a medicine service.
So the ethical issues are much there, I think. It is being studied, that is what I understand.
Most of the time when the telemedicines are going on, it is just like you are dispensing patient in your OPD, accepting the haptic sensation, accepting that. So this is only an extension of your OPD consultation. I don't think much a problem is there in this case.
Okay, thank you, sir. So I think on that note, I think we can conclude this discussion part. We have discussed almost every point. If there is anything left, I think there will be some response very soon. And somebody was asking about whether this thing is available on the YouTube, and it is available. You can visit the IMA website and go to the links to get it. The link will be also sent to you. Already it is displayed here in this chat box. The YouTube and Instagram handles are displayed. So that is it. Over to Chairman to conclude the session, sir.
Thank you very much. And I must, from the core of my heart, thank all the speakers who have so beautifully spoken today about the subjects allotted to them, and the enthusiastic participation of various listeners who have come up with various pertinent questions has made this whole exercise a very great success in that way. And we hope that in the coming days, when we'll be holding our third edition, fourth edition of this ethics webinars, I think everybody will join and ask their friends also to join, so that we have a bigger and a stronger platform to discuss these very important questions. And I thank very much my erstwhile colleagues, Professor Ved Prakash Mishra, Danteshwar Hota, Iran, Bhavin Kothari, Nilesh Parikh, and also my thanks to Dr. M. Menon, who has so beautifully conducted and organized this particular webinar. So thanking you all. Have a very nice day.
Thank you, sir.
Thank you, sir. Thank you all the faculties and all the chairpersons and delegates. Thank you very much. Bye.
Thank you, sir. Thank you.